Hi guys, welcome back. The next topic we're studying is acute coronary syndrome. This topic is highly important not only from the exam perspective but even from your clinical practice perspective as well, because you would come across large number of cases of coronary artery disease both in your practice as well as in your family. You are very well aware of the fact that coronary artery disease per se contributes to 30% mortality. I mean, that's much more than other conditions, including COVID. So I want to highlight this fact that in your clinical practice, you're going to come across large number of cases who might actually come to you very late. They might be having cardiogenic shock post myocardial infarction. And in spite of your best efforts, you may not be able to save them as well. Though our objective today would be two things. One would be early identification and second would be learning the management of patients. But I want to highlight this fact: coronary artery disease per se is one of the biggest contributors to mortality in both India as well as in America. I mean, whether you sit for a USMLE exam or for an Indian exam, the answer for the biggest contributor to mortality remains the same. On this, the usual query of most of the patients would be that, sir, why is it happening? Then one single English word that explains all the bad things that I'm going to talk about you in the next 2 hours is going to be atherosclerosis. And as you can see from the name, atherosclerosis implies there's going to be fibrosis in the coronary artery. This fibrosis can not only cause narrowing and reduction in the lumen of the artery, but God forbid if this fibrotic area or this fibrotic plaque fissures, then there could be a collagen exposure, and the moment collagen is exposed, the platelets will jump onto that opportunity and will cause a clot formation or thrombus formation, and within few seconds or minutes the whole coronary artery or a part of it might actually become thrombosed, due to which the blood supply to the cardiac muscle would be obviously cut off, and this would result in substantial amount of necrosis in the heart. So this is one of the biggest killers in the world that we are going to talk about at the moment. And I also want to at the moment say this term, accelerated atherosclerosis. Though accelerated atherosclerosis implies the disease can be developing as early as maybe 40 years of age, sometimes even younger. So accelerated atherosclerosis can not only be seen in people with morbid obesity, but even when you will listen to me talking about diabetes mellitus patients, there are macrovascular complication that occurs in diabetes mellitus patients and contributes to death is coronary artery disease. Apart from this, even in hypothyroidism topic, I will say the word accelerated atherosclerosis, which implies that the disease is occurring relatively early. So obviously preventive measures have to be instituted in the form of, for example, statins in patients in whom cholesterol and especially triglyceride values or bad cholesterol LDL values are elevated. Even in the rheumatology section, you will hear me say that in SLE patients, who's obviously gonna be woman most of the time, then this lady after 45 years of age can expire due to coronary artery disease. So is the case with rheumatoid arthritis. So I just want you to remember a couple of important causes of accelerated atherosclerosis. It implies the fact that the disease will develop relatively early, maybe in their 40s. And I also want to highlight that if you compare Indian population with American population, the incidence of atherosclerosis and rather the development of atherosclerosis begins in Indian population earlier as compared to American population. Why that is so, I'll also explain to you as we progress in the discussion, but we Indians are more predisposed to having heart disease as compared to American population. The impression is that Americans eat lot of fat, lot of cheese, lots of restaurant food, McDonald's, etc. But I want to tell you that even Indian cooking will have some kind of, bad habits or bad cooking practices which will contribute to trans fats generation, and that trans fat intake is one of the important reasons why Indians are now having morbid obesity or are having centripetal obesity, and as a result of it, the bad news is that the incidence of CAD or coronary artery disease is increasing. In fact, don't be under impression that per se atherosclerosis can involve only and only the coronary arteries. You would be knowing from your basic classes in pathology that even abdominal aorta can be involved in the process of atherosclerosis. In fact, I just want you to remind a mnemonic by the name of ACP, where I have written the data in decreasing order of prevalence. Abdominal aorta, coronary arteries, and popliteal arteries are the ones which can be involved by atherosclerotic lesions, and thereby varied clinical profiles will occur. In fact, not only can popliteal artery be involved, but even the blood vessels that contribute to the circle of Willis can be involved, which explains to you that why transient ischemic attack or stroke manifestations will occur. Please appreciate the fact that if abdominal aorta is involved, then most of the time the bad news will be in the form of a abdominal aorta aneurysm. And you know from your surgery classes that if the size of this one is going to go beyond more than 5.5 centimeter, then God help this guy, because there's a possibility of a spontaneous rupture. You see, lots of time it may not cause very substantial symptoms. If it is initially causing symptoms in the form of abdominal pain, discomfort, if a person seeks your services earlier, obviously you would be able to pick it up and this would be a pulsatile swelling. But otherwise, if it is not going to cause any dramatic symptoms, there is a possibility it can rupture and the person might die and nothing much can be done to save the life of this person. When it comes to coronary artery involvement, that's the main perspective this entire discussion. One can be that the person says that, sir, I was walking towards my car in the parking lot. Like this gentleman, he is, let me say, 50 to 60 years of age, and he is a cigarette smoker as well, atherosclerotic risk factor, and he is walking fast towards his car in the parking lot, and in walking fast, he's having chest pain or combination of chest pain coming on exertion plus emotion. Like this guy says that I was walking fast and I was talking to somebody on the cell phone, maybe with his family member, and he was having a fight with that family member. So when you tend to speak loud, when you angry on somebody, then obviously the sympathomimetic drive will increase. So in this person, he says that I was fighting with some family member on the phone, not a very serious fight, just a minor issue, minor tussle. But the problem is the combination of exertion and emotion can contribute to severe chest pain in this person. But the good news is, once the person will rather stop talking or stop fighting and will sit down at one place, the chest pain is going to disappear. This kind of a presentation that I'm going to explain to you subsequently, where you get chest pain, especially on exercise, is seen with at least 70% blockage. That is itself a question, that how much percentage of blockage should be present in any one coronary artery to cause symptoms developing in a person of chest pain on exercise. That it's going to be answered as the value that I've written, 70%. In fact, in some patients, there's a possibility that the atherosclerotic plaque might fissure. Collagen will be exposed, platelets will jump onto that opportunity, and the person can have a myocardial infarction, which will be of two varieties that I'll explain to you. One is going to be STEMI, and second is going to be non-ST elevation MI, and the treatment of both of them is different, as will be explained to you as we go on in our journey. There's also a possibility that some patients might be having unstable angina. So I will be teaching you regarding differences in ECG and biomarkers with respect to STEMI, non-ST elevation MI, and unstable angina. And at this juncture, I'm also using this opportunity to mention before you the three differentials of the main topic that we're going to discuss, that is acute coronary syndrome. You see, at the moment, I'm being more broader and more generalized in the perspective by teaching you blood vessels which can be involved due to atherosclerosis per se. But atherosclerosis can cause multi-vessel involvement. I mean, a single patient could be having an abdominal aorta aneurysm, and the same guy can have a MI complication also, or it might be two different patients. But the information that I have currently put in the blue box is the one which is the differential diagnosis of acute coronary syndrome. There are three differentials: STEMI, non-ST elevation MI, unstable angina. The majority of the time, I'm gonna invest into explaining to you how to differentiate between them, and usually the time that you get in the MCQ is approximately 1 minute. So my objective would be to explain to you how can you differentiate them, or per se, I mean, what are the keywords in the question that would help you identify the three disorders. In fact, lots of time you will also notice that he will try to confuse you by incorporating conditions where a person will again be having chest pain at rest, but this is going to be due to spasm of the coronary artery. The condition is called as Prinzmetal angina / variant angina. Why it is called variant angina is because this is the only angina where you get a ST elevation. All other anginas, whether it's going to be chronic stable angina per se, that's going to be having a ST depression, maybe on a treadmill test, but Prinzmetal angina always has a ST elevation. So as we progress in the discussion, you will feel more comfortable with these terminologies. But at the moment, the minimum perspective I want you to remember is there are three differentials of acute coronary syndrome, and you also need to know in decreasing order of importance blood vessels involved in atherosclerosis topic. And well, when it comes to popliteal artery involvement, this you don't need to note down, that is implied, and this is taught even in surgery, that peripheral arterial disease can occur, so a person can be having claudication. Mark my words there, I did not say intermittent claudication. That is what you read with Burgess disease, which is going to be more commonly seen less than 45 and non-smokers. But at the moment, I'm talking about a smoker more than 45 years of age, popliteal artery narrowing. And God forbid, if circle of Willis is involved, then either you could be having a transient ischemic attack, or you could be having a stroke manifestation. So you can see one simple word, atherosclerosis, is having so many ramifications, so many implications for a single patient, or these could be different patients as well. I repeat the fact once again, acute coronary syndrome would be having the following differentials that I have just at the moment explained to you. That is going to be STEMI, non-ST elevation MI, and unstable angina. Now, in the exam, what he usually does is just to trouble you because you are in a rush to answer, he might just very subtly change the term. He might write acute chest syndrome. And one of my students who pointed this post exam said, Sir, he was very smart. I mean, I literally almost neglected the word acute chest syndrome. I thought he's asking acute coronary syndrome. Acute chest syndrome is what you read in hematology with sickle cell anemia. You see, the problem in sickle cell anemia is that the RBCs will become relatively more sticky. So if we take this as one of the small blood vessels in the heart per se, let me say this is a perforator. We have epicardial coronary arteries, then we have the branches. The branches is the perforator. So at the branching point of the perforator, the sticky RBCs might actually stick to each other and might cut off the blood supply to the distal circulation, result in obviously myocardial ischemia and development of chest pain and even elevated biomarkers in some cases. Please remember the fact that if he says the word acute coronary syndrome is caused by, answer is atherosclerosis, the biggest killer in the world as I explained to you. But if he says acute chest syndrome is caused by, then the answer would be called as this autosomal recessive condition, which is fairly more common in those countries or areas where malaria is endemic, that is sickle cell anemia. Though I have discussed about acute chest syndrome as a terminology even in hematology, but it is important that I highlight the terms before you very clearly. Acute coronary syndrome is by atherosclerosis and acute chest syndrome per se is by sickle cell anemia. And there are three differentials of acute coronary syndrome that at the moment have been highlighted. Now, as they say, there is no point of crying over spilt milk. So, are we in a position to identify atherosclerosis before it has caused such bad prognosis, before it has caused all these problems that I've discussed? Yes, we do have some tests available, and we as doctors are always in a mode or always in, I would say, search for those special markers which will help us in early identification of the disease. So, I'm now going to teach you regarding markers for atherosclerosis. Our objective would be to talk about and discuss about what are the blood tests that you can write to an individual, maybe in his early 40s, maybe in his early 50s, so that you can know that, okay, this guy in future will develop heart disease. One of the very important markers for atherosclerosis is HSCRP, that is high sensitivity CRP. Please remember it is different from plain CRP in a sense that this would be relatively more accurate for the inflammatory processes going on in the body, which is responsible for atherosclerosis. If high sensitivity CRP is positive, like let me say I have a young doctor today coming to me and he says that my father had heart attack or myocardial infarction at 55 years of age. You see, casual word for myocardial infarction in India is heart attack. The technical word is myocardial infarction. So this young guy, right, he's a budding doctor and he's telling me that my father had a MI at 55 years of age. Would I also develop a similar kind of a presentation when I go 55? I'll tell him, buddy, let's get this test on you. He said, okay, boss, he got this test. It turned out to be positive. He's asking me, sir, what does this test imply? I'll tell him that this test is if it is positive, obviously there's a cutoff value. You don't need to go into a cutoff value. But if this test is strongly positive, then this means that even this young doctor, when he grows up to be his dad's age, can develop myocardial infarction. So this test is a predictor for future coronary events. Those coronary events can range from, it could be any of the two varieties of MI, it could be unstable angina developing. But the point is that can we in young age predict whether somebody in old age will develop heart disease? Yes, we can as of now. High sensitivity CRP from MCQ language should be remembered as a predictor for future coronary events. And after that will be obviously the traditional information that even non-medicos would be familiar with, that is elevated total cholesterol. Because you see, all these cooking oils, they are definitely, or advertisements of cooking oils are doing a very good job in educating especially Indian population with respect to incidence of heart disease. Total cholesterol divided by the HDL ratio. You very well know HDL would be the good cholesterol and LDL is the bad cholesterol. If this ratio is more than 3.5, in fact it's a range, right, 3.5 to 5.5. I mean, the more you go higher, that means that the incidence of heart disease will increase. So I just want to highlight that everything in medicine is a range, like it's given as a range actually, and the higher you go up, I mean, if the value is more than 5.5, then the incidence will be higher. Then I would say between 3.5 to 5.5, it would be moderate risk. And the message is that now we are developing drugs to actually regulate the values of total cholesterol as well as LDL, and we'll talk about these drugs subsequently. The next important marker for atherosclerosis that I want you to remember is written as lipoprotein A. Now please remember that in the numerator it is written as lipoprotein A. In the denominator what we are taking here is apolipoprotein B. Now, though you have read about this in biochemistry as well, you have read about this in other basic sciences classes, I just want to draw your attention to the fact that the apo word per se is not in the numerator, it is in the denominator, because the moment you start talking about apolipoprotein A with a capital A, then we are definitely talking about apolipoprotein A with a capital A with respect to HDL, and HDL is going to be cardioprotective. This is lipoprotein A. It might be written as capital L, small p, small a. This is a atherogenic particle, and this is an independent risk factor for coronary artery disease. Now there's no cutoff values here, but I just want you to remember the fact that higher the value of lipoprotein A and divided by apolipoprotein B, I mean the numerator is higher, denominator is lesser, the incidence of CAD will definitely increase in the person. And most good quality laboratories nowadays, they not only check for total cholesterol, triglycerides, LDL, HDL, but they'll also be doing complementary apolipoprotein B values that can help you identify whether a person is at risk for development of coronary artery disease or not. You would have also seen that we Indians develop heart disease maybe in 60s. In fact, even earlier, maybe even in, I would say, late 40s. We can take example of our former captain Saurav Ganguly. Saurav Ganguly is only 48 years of age, and when he was running on the treadmill in his house, and he's a fit guy. I mean, to be a captain of Indian cricket team, you obviously need to have a certain level of fitness. So Saurav Ganguly is a fit guy, but he was found to be having blockages in his coronary artery, and that's again because of the eating habits we Indians have. So as I highlighted, Indians are developing heart disease younger at a younger age as compared to American population. Why is that so? Is because of this autosomal recessive condition, homocystinemia. We Indians are having this genetic condition. The amino acid homocysteine levels are found to be elevated, and because of this we tend to have premature atherosclerosis. And the word of caution from my side at the moment is that I've seen a lot of people messing up in the MCQ. One is gonna be predictor versus premature atherosclerosis. You can see the words are overlapping, but they have a different meaning per se. So if you get a question that says what is the predictor for future coronary events, like a young guy 25 years of age, he wants to know will he develop MI like his dad at 55, high sensitivity CRP. If it's gonna be premature atherosclerosis, I gave example of Saurav Ganguly sir, that's gonna be homocystinemia, and we definitely have strategy to counter that as well in the form of vitamin B6, B9 and B12, and the treatment for that will definitely be talked about subsequently. I at this junction want to highlight that vitamin E, right? It's an antioxidant, and we as doctors are always bred on the concept that antioxidants are good for heart. But I want to tell you a very surprising statement which was picked up from Harrison and were asked in the exam. Vitamin E per se worsens coronary artery disease. Guys, this might initially come as a shock to you, because right through our medical college it is drilled into our heads that antioxidants are going to be good for diabetic patients, good for heart disease patients. Yes, antioxidants are good for diabetics, but vitamin E per se, the antioxidant, worsens coronary artery disease. So we are not supposed to give rather vitamin E for management of homocystinemia. As I said verbally, I'm writing it down here for record's sake. It is vitamin B6, B9, B12. In fact, lots of physicians you will notice are always writing these vitamins to especially Indian patients having homocystinemia, and 4 of you will get this test done. Out of 4, maybe 2 of you young doctors could be having elevated homocysteine levels. I mean, that is high, the prevalence levels. Now, moving ahead, I also want to talk about the conventional stuff, that is LDL. The higher the values and lower is the values of the good cholesterol HDL, the incidence of heart disease rather increases. And the way I have mentioned this information, I also want to say that this data is giving in decreasing order of importance. So suppose these parameters are given in a single question and they ask you to select one, and he says which of these is the major determinant that will develop or will be responsible for development of coronary artery disease. The single best answer that you will give in the exam will be high sensitivity CRP. You can see that as we are going down, I mean, this is the standard textbook data, that as we are going down, the importance of the risk factor is relatively reducing. On this, I also want to draw your attention to a very interesting fact. You see, there can obviously be a fight between a person having low HDL versus a person having a high LDL. You very well know that if good cholesterol is lesser, heart disease will increase. Bad cholesterol is more, heart disease will increase. But let us compare the two head on. I mean, which of the two is more important? Now, if you look at this numbering or sequencing that I've done, you will notice the fact that HDL is given in point number 2 also and is given in point number 6 also. But as I highlighted, point number 2 is more important. Remember, I told you that the information is given in decreasing order of importance. Most important parameter, HSCRP. Second most important, total cholesterol HDL deficiency. I want to tell you that deficiency of HDL is more important a risk factor as compared to elevation of bad cholesterol. Lots of you might here send a query to me. No, sir, it is, we have read bad cholesterol is gonna be the main contributor. Yes, I agree to that. But on a head-to-head comparison, they have done clinical studies here and they found the fact that it is rather the deficiency of the good cholesterol which is more important a parameter as compared to elevation of LDL. So when you get a question like this where comparison between the two is done, this is the data that I basically want you to follow. And at the same time, I can say that if somebody is having elevated LDL, you definitely have statins available. No, you can use drugs to decrease the values of low density lipoprotein, but we do not have drugs that can cause a dramatic increase in the value of HDL. Yeah, we can use drugs like niacin, but then a lot of side effects also that you will see, like flushing or itching or pruritus that can develop in a patient. So as of now, medical science still has a big lacune. Though a lot of research are going in here for lots of categories which are being used to increase the value of HDL. But at the moment, we have not been able to cause a substantial rise, significant rise of high density lipoprotein to decrease the day we are able to develop a drug that causes elevation of HDL substantially and we start giving it to Indian population, the incidence of coronary artery disease in India will dramatically reduce. These are important risk factors that I want you to remember, especially from the perspective of the exam. And over and above this, another important thing that comes up here is that suppose somebody is having elevated LDL, then what should be done? Should we start statins in a person? I want to here sensitize you to an online health calculator available by the name of Framingham. Please remember, one is Framingham criteria. They are useful for diagnosis of congestive heart failure. When you go through the CHF topic, I have talked about Framingham criteria. But at the moment, I am teaching you an alternative terminology, which is again beginning with the word Framingham, but this is gonna be a Framingham online calculator or a Framingham score, which can be used to actually check out the 10-year mortality rate of an individual and then decide whether that person will require statins or not. I repeat the fact once again. One is Framingham criteria for determining the presence or absence of congestive heart failure. We have major criteria, we have minor criteria, but then we have a Framingham score also. The advantage of this Framingham score is that it can calculate a 10-year mortality for an individual. This is available online, and the person needs to put in standard information like the age, gender, whether he's a smoker or not, the values of cholesterol, that is the bad cholesterol value specifically, and a couple of other paraphernalia, and the software will tell you that what are the chances that the person will develop a coronary event in the next 10 years. If the value turns out to be more than 10%, I repeat the fact once again, though this is not important exam wise, but in this Framingham score calculator, if the value turns out to be more than 10% mortality over the next 10 years, then definitely a person would be having a requirement of starting the statins. The main objective starting the statins would be to cause a substantial reduction in the value of low density lipoprotein. So what should be the cutoff LDL for normal population? You see, for very high risk population like diabetics, the cutoffs will be different from that of ordinary population. So the values of LDL keep on changing. You see, till last year, the cutoff for LDL here was 130 for ordinary population. But now for ordinary population or low to moderate risk population, he's mentioning it as relatively value of less than 115. So usually, most of the time, you see, every year they keep on modulating this data. And that is why I thought that I'll just introduce this slight update here as well, that for a person with Framingham 10-year mortality calculator, if it turns out to be low to moderate risk, then the target value that you need to obtain is less than 115. But if a person is a high risk patient, example of high risk patient can be like he is having a family history of coronary artery disease and he's a smoker as well. He has a sedentary lifestyle, and let me say he also is obese. The more you increase the risk factors for coronary artery disease, more the risk of the person will definitely increase. And for those patients, the cutoff for LDL has been now less than 100 milligram percent. But I can now introduce a person who I can call as very high risk. Now, obviously, lots of time you might say, sir, how is it possible to remember all these aspects? So the minimum I expect you to remember is what I will say next. Suppose in the exam, he gives you a scenario for diabetic patient, or he says that this diabetic has already developed chronic kidney disease, or he gives you a scenario that person is on hemodialysis. You very well know hemodialysis itself causes exerted atherosclerosis. So these are patients who are, I would classify as very high risk patients. In these patients, the value of low density lipoprotein should be kept as less than 70 milligram percent. In fact, there is no change if you compare this data with respect to last year notes per se, because I've said this statement earlier also. At the moment I've just introduced terms like low, high risk or very high risk. The standard information which is same as last year is for diabetic patients, for CKD patients, hemodialysis patients, because the risk of coronary events is more. The target of LDL is different from ordinary population, and out of these values, at least one that I wanted to remember is what I have just said. Keep the values as less than 70 milligram percent. That's the main objective in any diabetic or any person with diabetes with chronic kidney disease, because you will notice that the number one cause of chronic kidney disease again happens to be diabetes mellitus, and the combination of the two increases the cardiovascular mortality. The message here are two. One, you need to remember Framingham criteria, which are discussed in congestive heart failure. Framingham score per se is an online calculator by which you can know the 10-year mortality rate based on the values of the bad cholesterol, age, and couple of other paraphernalia or information like smoking, etc. The message is that for diabetic population, try to keep these values less than 70 with usage of high intensity statin. And you very well know that one of the biggest problem with statins usage is muscle pain. So whenever you're writing statins to your patient, and you always are gonna explain to the patient that if you have pain in your legs, if you have pain in your muscles, if you feel extremely tired, very lethargic, you don't feel like going to your office, not doing anything, we will do a blood test in you, that is CPK-MM. I mean, it should not come as a rude shock to the patient that you have not informed the side effects of statins, and he starts developing a statin associated myopathy, and it is a later diagnosis that you make. So it's always advisable whenever you give statins, one, always give them at bedtime because maximum cholesterol synthesis occurs at night, and second, always inform the patient about the side effect at the time of introduction itself, that if you have muscle pain, you need to come back to me. I mean, try to make it I would say medico-legally safe for you, and at the same time give a proper information to the patient so that he can make a proper decision about reducing his risk of developing heart disease per se. Next, based on the explanation of atherosclerosis per se, I am now going to show you two coronary arteries of two different patients. The yellow in this case is representing the atherosclerotic plaque, where there's going to be presence of foam cells. Well, foam cells are modified macrophages, and they're called as foam cells because the cytoplasm is not clear, primarily because there is presence of the oxidized form of LDL. You see, this oxidized LDL is the trigger which is then responsible for formation of the second layer in atherosclerosis, which is shown in color blue at the moment, that is fibrous cap. I first want to highlight that atherosclerosis, which can involve so many blood vessels in the body, as I explained in the previous slide, will be having two layers: the fibrous cap on the top, which is shown in color blue, and inferiorly is the fat, which is technically the foam cells. The cytoplasm is foamy because of the oxidized LDL component. Now, when you compare the two images, you definitely can see more significant fibrosis in the image where I have put a star mark, and if you look at the image contralateral to it, there is relatively less fibrosis. Well, in the first look, it looks as if only the person where I put the star mark will be symptomatic, but let us see what can actually happen in this particular image that I'm zooming in at the moment. When blood will go through this coronary artery at high pressure, there's a possibility that there might be a fissure developing in the atherosclerotic plaque, or a tear developing in the atherosclerotic plaque. And the moment a tear will develop here, the platelets will be attracted to collagen. Very well, or very soon there will be a platelet plug that will be formed here that I've shown in dotted black, and once the platelets are activated, the clotting system will also be activated, and what I'm drawing at the moment is a thrombus in the coronary artery. In fact, this thrombus might actually become so big that it might cause a complete luminal obstruction, and the person can develop a myocardial infarction. Well, the event that I described in this person who's having relatively less amount of atherosclerosis is plaque fissure. Don't be under impression that less atherosclerosis is not going to be dangerous. Even less atherosclerosis can be dangerous enough to a level that the moment it tears, the platelets are going to jump onto the opportunity and the thrombus can cause a complete luminal obstruction. So the technical word that I'm going to use for the first cut section that I've shown, which is having less atherosclerosis, is that this person is having a vulnerable plaque. What I mean by vulnerable is that because there is less fibrosis, so it is more prone to rupture. On the right hand side, if you look at the second one where I put the star mark, because there is more fibrosis, the chances of this having a tear is lesser. It's not that the one on the right cannot have a tear. Yes, it definitely can have a tear, but rather the main problem in this person will be a significant luminal obstruction or luminal reduction. So the amount of blood supply that will go in distal circulation in this person will be lesser. And if there's going to be more than 70% blockage of this particular coronary artery, then there could be chest pain on exercise or emotion or a combination of the two. In fact, in some patients, even after eating food, there might be chest pain. For the right hand side, I want to say the word non-vulnerable plaque. What I imply by the word non-vulnerable is that the chances of myocardial infarction will be relatively, I'm saying relatively lesser when it comes to the one which I've written as non-vulnerable plaque, chances of chronic stable angina, because the artery itself is narrowed, therefore chronic stable angina incidence will be relatively higher. Now, why are we studying this is because atherosclerosis, whether mild or more or severe, both are dangerous. In fact, little atherosclerosis is more dangerous than significant amount of atherosclerosis. Why? Because it is vulnerable to the shearing forces in the blood vessel. In the moment it shears, the platelets, as I explained, can jump onto the opportunity and they can be a thrombus formation. Our objective here is to understand or is to study that do we have any, I would say, investigation available as of today in the form of imaging by which we can differentiate between a vulnerable plaque versus a non-vulnerable plaque. Because what I'm doing here is risk stratification. I want to know, is my patient more vulnerable to development of MI? Is my patient more vulnerable to chances of development of chronic stable angina? Well, one of the investigations that I obviously have available is coronary angiography. But as you are aware, coronary angiography would mean that it has to be an invasive process. You either have to go through a transradial approach or you will have to go in for a transfemoral approach. And try telling this to a non-medical person that I'm going to puncture your radial artery or I'm going to puncture your femoral artery and go retrogradely towards the heart. The person is simply going to run away. So do we have at the moment any non-invasive imaging available by which we are able to differentiate between the two conditions is the reason for discussion of this particular slide. And I want you to remember this imaging available, which is MDCT, that is multi-detector CT scan. MDCT is a non-invasive imaging modality which can actually take sections of the coronary artery millimeter by millimeter and can tell us regarding whether the person is having a vulnerable plaque or a non-vulnerable plaque. And over and above this, we also have available intravascular ultrasound. Now, when I say the word IVUS, that is intravascular ultrasound, you can very well understand for intravascular ultrasound, the ultrasound probe has to be sent right in that coronary artery. So that means it again becomes invasive. So the main concept which I want you to remember at the moment from the MCQ domain is there are two messages in fact from this slide. One, atherosclerosis, less or more, both is dangerous. In fact, having lesser is more dangerous. Why? Because it's a vulnerable plaque. So chances of MI will be relatively higher. If atherosclerosis is more, anyway bad news because person will develop chronic stable angina. To differentiate between vulnerable and a non-vulnerable plaque, we can go in for a multi-detector CT scan, and in the same patients, both the first and the second image, in both of these patients, in the long run, there can even be calcification developing in the coronary artery. Listen to my next statement very carefully. I said in the long run, whenever blood vessels are involved, you always read about calcification of the coronary artery can also develop. And if the calcification will develop, then we have a scoring available. What I mean by scoring is that is the calcification present in 25% of the circumference, 50% of the circumference, 75% of the circumference, or all 100% of the circumference of the blood vessel is having a calcification. So to determine this calcification of the coronary artery or the severity of calcification per se, we have a scoring also available. Now, you very well know that for calcification, CT scan is good enough. So I'm talking about multi-detector CT scan only. But what I'm trying to teach you is regarding a score which has been asked in the exam. This is discussed even in radiology by sometimes by radiologists as well. That is Agatston score. In fact, the question in the exam was Agatston score is useful for evaluation of. So usually you read about various kinds of scores in surgery, but today I'm teaching you a score in medicine called as Agatston score. Well, what is it used for? It is used to determine the severity of calcification of the coronary artery on a long-term basis, and more will be the possibility of atherosclerotic lesion. The longer the duration is of the atherosclerotic lesion, more will be the chances of calcification, and we can pick up this calcification by MDCT. So the number of concepts here has increased to 3. I'll repeat the concepts once again. One, you should be knowing difference between vulnerable and non-vulnerable plaque, which I've already explained. Incidence of MI being higher, chronic stable angina being higher. How do you differentiate between the two? Easy, multi-detector CT scan. In the long run, both of these patients can have a calcification as well. The score used for calcification is going to be called as Agatston score primarily. Now, based on this background information, my objective was one, to sensitize you to how bad this disease is, that it can cause so many blood vessels involvement and thereby so many manifestations in a person. Then I wanted to explain to you how can we pick it up relatively early. And then I also wanted to explain that little atherosclerosis versus more severe atherosclerosis. I mean, atherosclerosis of any kind is bad. It's a merciless disease. It will cause multiple manifestations in a person. And now I will focus on this particular person who's having a substantial fibrosis in the coronary artery. So in the next part of the slide, I'm going to explain to you how a person of chronic stable angina will present to you. In fact, lots of time, because chronic stable angina, the name itself, gives stability to the diagnosis and even makes the person feel relatively more comfortable when you write this word, as compared to myocardial infarction, which looks like a relatively more dangerous disease. Chronic stable angina in lot of MCQs, because he knows that you'll be able to crack the question, will be written by the examiner as reversible ischemia. Now that itself looks like an enigma, no? Because traditionally ischemia is supposed to be irreversible. So let me explain to you what I mean by the word reversible ischemia here. This particular person is having substantial narrowing of the coronary artery. You see, atherosclerosis begins by involving tunica intima. Initially, I've just shown fat. Subsequently, I've shown a fibrous cap, and this is the status of this guy when he was in 40s, and let me say he's a big time smoker, maybe does 2 packets of cigarette every day. So though his family members, his wife, his children had asked him to give up smoking because he smells so bad of nicotine all the time, but this guy, oblivious to everybody else, continues to smoke. And as he will continue to smoke, smoking is an important risk factor for heart disease. The atherosclerotic and the fibrosis component, which are shown in blue, will continue to increase. Let us now look at the coronary arteries of this guy. Let me say when he's going to be 60 years of age, the same guy, he has been smoking from, let me say, 25 years of age when he got his first job, and now there's a substantial narrowing of the lumen of the coronary artery. Whenever he will walk fast, he will start having symptoms of chest pain. The traditional MCQ will always describe a male patient. The incidence of atherosclerosis or heart disease is relatively more in men, though post-menopausal women have equal risk as men of the same age group. You very well know that before 45, women will be protected by estrogen, but then the effect tends to wear off, especially in a post-menopausal scenario. So I've deliberately talked about a male patient here. He's a big time smoker. He's maybe retired as a teacher, maybe from a college, and he also has hypertension, but he does not take medication for hypertension. He maybe takes Baba Ramdev's medication, Ayurveda, homeopathy stuff, but is very irregular with our medication per se. Now, this gentleman is at the moment walking fast towards his car in the parking lot. Let me say it is his daughter's marriage, and he's late for a function, or he's maybe late for some appointment. And he was maybe talking to somebody on the cell phone also that, okay, I'm coming. So he was a bit stressed out because he's late per se. So on the combination of exercise and emotion, I repeat the fact once again, walking fast towards his car in the parking lot, and while at the same time talking on the cell phone, the combination of exertion and emotion will trigger chest pain. In fact, the chest pain will be so bad that this gentleman might actually clutch his chest and might sit down in the floor of the parking lot. He might be wearing expensive clothes, but at the same time, when he's sitting on the floor of the parking lot, those clothes might even become dirty. And if the parking lot attendant would have come and would have said, sir, can I help you? But the pain of this guy was so bad that he was just sitting clutching his chest. And at that point of time, even if his cell phone is ringing, maybe his daughter is calling him up and saying, Dad, where are you? This guy will not have the energy and the capacity to simply, switch on a button on the phone, put on the speaker, and tell his family member that, can you send me an ambulance? I am at a particular parking lot in this particular part of the city. So the pain was be very excruciating in these people, and usually the duration of chest pain can be anything between 5 to 10 minutes. I'll write here the upper limit usually that we see. And gradually when he will sit down, because now there is no physical exertion at the moment, is not talking on the cell phone, so gradually the chest pain will ease off. And because the symptoms are reversing in this individual or are regressing in this individual, that is why we call it a reversible ischemia. The basic message is that in patients of chronic stable angina, there can be diffuse chest pain present, but unlike in myocardial infarction, you see, once MI will occur, because there's a irreversible ischemia, because MI is because of a thrombus in the coronary artery, the muscle will die. In this case, there is no death of the muscle, there is no myonecrosis, so therefore cardiac biomarkers will always be normal in chronic stable angina, but will always be elevated in myocardial infarction. So whenever in doubt, you can obviously do cardiac biomarkers for a easy detection. This particular gentleman had severe episode of diffuse chest pain on combination of exertion and emotion. In the question, he will mention also that this has happened earlier also, and every time he gets the relief. So maybe last time the attack was not so bad, and that is the reason maybe he did not decide to see a doctor. But this time he's really gonna be scared. I mean, during this attack, he's gonna be all sweating profusely. He's gonna be having breathlessness issues, and he will tell the doctor that I thought I will die. I will never see my son, daughter, or family members again. But gradually the pain will ease off. So there's definitely a relief on rest in these patients, or obviously with medication. If you give nitrates to these people, the duration of chest pain definitely is going to be something in the range of 5 to 10 minutes, can be a little more or a little less. And in fact, this person might even give you an interesting piece of information. Sir, when I ate my dinner last night, I was having heaviness in my chest. I thought I had eaten some oily food, like, if there's a marriage party in the house, there might be cooks from outside. They will obviously be making food that is relatively heavy. So this person is actually thinking that he's having some kind of indigestion, but you will definitely get this history in the retrospective basis in the individual, that is postprandial angina. At this particular junction, I want to highlight that if you read about an individual who's like, let me say 60, 70 years of age, and he says, sir, every time I eat food, I start having severe abdominal pain to the level that I've stopped eating food. Guys, at the moment I'm discussing another topic with you, though the main topic of the discussion is chronic stable angina. I am teaching you regarding what is called as abdominal angina. Abdominal angina again occurs because of atherosclerotic narrowing of the superior mesenteric artery. You can see that atherosclerosis is such a nasty disease that it can obviously cause involvement of ACP, the abdominal aorta, coronary and popliteal artery, but it can even cause narrowing of the superior mesenteric artery. So person can be having chest pain, or in contrast to chest pain in chronic stable angina, this particular individual will be having abdominal pain. So read the question with care. That's what I want to highlight. If he mentions the word postprandial chest pain, I repeat the fact once again, in the information that I was talking about initially, the one that is being discussed at the moment, when I read the word postprandial angina, it basically means chest pain after eating food. In contrast, when I'm talking about the information parallel to this postprandial abdominal pain, then it's gonna be abdominal angina, and usually the description given for the left hand side will be chronic mesenteric insufficiency. Chronic mesenteric insufficiency simply implies, as the name itself is self-explanatory, there's going to be narrowing of the mesenteric artery, so the blood supply to the gut will be lesser, whereas traditionally postprandially the blood supply to the gut should increase for digestive purposes. So do read the question with lot of care. Is it postprandial chest pain? Is it postprandial abdominal pain? Because both are due to atherosclerosis, but the manifestations are grossly different. I mean, the blood vessel involvement is different. In chronic stable angina, they could be narrowing of the left anterior descending artery, left coronary artery, right coronary artery, whereas in postprandial abdominal angina or postprandial abdominal pain, it's going to be superior mesenteric artery that would be involved. We come back to our case once again. This guy has now cancelled all kind of function, etc., and has decided to come over to your clinic. He is accompanied by his son, his daughter, and because he had this episode of chest pain, you decided to do a ECG. When you will show the ECG printout to these people, they'll obviously expect an interpretation, and you will tell them that the ECG findings are normal, and his son and daughter are looking at you in disbelief. They say, sir, my father was in so much of chest pain and thankfully he's alive, and he was so bad, and you were telling us ECG is normal. Is there nothing wrong with the heart of our dad? How is it possible? So I will explain to this young individual who's accompanying this relative old man is that had your dad come to me when he was symptomatic. Remember when he came to the clinic, there was no chest pain. Chest pain occurred 1 hour back when he was at the parking lot. Then maybe somebody accompanied him or somebody escorted him to your clinic, or his son and daughter himself drove down to that site. When he felt better, he maybe called up his son and daughter. They drove down to the site and then drove him to your clinic. When he reached your clinic, he was not having any chest pain. So in an asymptomatic chap of chronic stable angina, ST segment is gonna be perfectly normal. But had this guy come to your clinic when he was symptomatic, let me say your clinic was just adjacent to the parking lot, and somebody escorted this gentleman who's sitting in the parking lot clutching his chest to your clinic per se, and at that circumstances when he was symptomatic, that is when if ECG was done, then it would have definitely shown evidence of ST segment depression. At this junction, I would have also asked my medic to give to this person sublingual nitroglycerin. And the moment sublingual nitroglycerin will be given, because it's a coronary vasodilator, it will improve the blood supply. You will notice that if you wait for few minutes, like let me say you repeated the ECG after 10 minutes. Now he's feeling relatively better. The ST segment of the person will become normalized. You can very well see why did I write the word reversible ischemia initially, because I wanted you to be clear about the fact that in these people, ECG findings will normalize. The chest pain symptoms will go away. Everything will become normal. The movement, there is no stress on the heart of the patient. It is a stressful event like walking fast. It is a stressful event of emotion or a combination of the two that can trigger chest pain manifestations, and everything becomes normal. The movement, the patient is feeling relatively comfortable, like you have given nitrate. So obviously the findings will normalize in this guy. I want to highlight the fact that because the ECG findings in large number of cases may be normal, because when the person comes to the clinic, he might be asymptomatic. He had chest pain yesterday. He had chest pain 1 hour back, 2 hour back. At the moment, he's okay. He's saying, sir, I had this earlier. Then you obviously need to run some tests on this guy to actually demonstrate that yes, there is some problem with the coronary arteries of the person. So now I'm going to address this particular scenario, that if the ECG is normal, in a asymptomatic patient of chronic stable angina, at the moment is asymptomatic, what am I gonna do? I'm gonna run a treadmill test in the patient. So therefore stress tests would be the answer for workup of this guy. In treadmill test, we will be using what is called as modified Bruce protocol. That is itself an MCQ. Bruce protocol is used for, your answer would be given as evaluation of a treadmill test report in a person. You see, we will not make the person run on the treadmill. It is just walking fast. So you will first tell the person that we are gradually gonna increase the speed of the treadmill. We are gradually gonna increase the incline of the treadmill every 3 minutes. So you yourself or your technician will be bedside or standing along with the person while he's walking on the treadmill. And every 3 minutes, there is an increase in the workload of the heart of this individual. I want to repeat this fact once again, that lots of time in India, people may not be very comfortable walking on a treadmill. They might slip and fall. There might be unnecessary injuries. So if a person is not comfortable, or if he's very fat, or let me say if he's having a non-healing ulcer on the sole of the foot, though I list out the contraindications subsequently, I just want to tell you right at the onset that don't force somebody to walk on a treadmill if he's not comfortable. We will gradually increase the speed. Like let me say it is 1.6 miles per hour at the moment. After 3 minutes, we'll increase the speed to 2 miles per hour. That's going to be rather slow walking. Then we increase the speed to 3 miles, and we'll gradually keep on increasing. And usually we make the patient go up to as fast as up to 6 miles per hour. And in a normal individual like you and me, when we will walk on the treadmill, you and me can run on the treadmill also, because our coronary arteries have no limitation. If you run fast, obviously your coronary arteries will dilate. They will provide the necessary oxygen, and your heart will be able to pump relatively better. But in this individual, there's a possibility that as the person will walk faster on the treadmill, the ECG attached will definitely start showing evidence of ST segment depression. Here he might deliberately write this word downsloping ST segment depression. So I will definitely, hand draw this before you, but I just want you to remember that downsloping ST segment depression is one of the findings that you will get. And well, for how long should the person walk on the treadmill? It is not, like 3 minutes or 4 minutes or 10 minutes. I mean, the capacity of every individual can vary about how much can you walk or how much can you run. Our objective is not for how long the patient can actually walk on the treadmill. Our objective is to attain the target heart rate. And what is the target heart rate? The formula for target heart rate is 85% of maximum possible physiologically. And what is the maximum heart rate possible physiologically? That is 220 minus age. Like, let me say if you're 20 years of age and you are a fit guy and you ask me how hard can I run on a treadmill, my answer is you can run so hard that your heart rate can go up to 200. Yes, at 20 years of age you can do so much of exercise that even if your heart rate is 200, nothing is going to happen to you. But at 60, somebody obviously cannot generate a heart rate of 200. The message is, we want to generate target heart rate in an individual. The formula for target heart rate is 85% of 220 minus age. Let's do some mathematics here. This is optional. I don't think so. You need to note it down. From mathematical calculations, I can say that for a 60-year-old guy, if you just look at the formula, 85% into 220 minus 60. So target heart rate will be something in the range of 140. That's the mathematical value that I have just generated before you from the formula. Now, suppose somebody at 60 years of age is walking on the treadmill. The display is showing a heart rate of 140, maybe 145, maybe heart rate of 150. He has attained that heart rate and the ECG is normal. This tells you that there are no blockages in the coronary artery of the patient. We need to look for some other causes that could have resulted in chest pain in this guy. But suppose for the same 60-year-old man, the target heart rate of 140 was not achieved. Let me say the heart rate on the display at the moment is only 120 or 125 or maybe 130. And at that moment, the ECG of this person starts showing evidence of ST segment depression. That means there is blockages in the coronary artery. I want to repeat this fact again. If somebody has attained the target heart rate, that means his coronary arteries are definitely of normal caliber. They are able to provide proper amount of oxygen. That is why the ECG is normal. But if somebody is not able to achieve target heart rate and ECG is showing ST segment depression, that is obviously a cause of concern. What should be the magnitude of ST segment depression to be considered significant than at least 1 millimeter and should be persisting for at least 2 small squares in the ECG? One small square in the ECG is 40 milliseconds. So I said ST depression of more than 1 millimeter persisting for at least 80 milliseconds in at least 2 contiguous leads. Let me say 2 contiguous leads would be like, for example, lead number V1, V2 or V3, V4 or V5, V6. So if I get this finding present, it means that I need to reduce the speed of the treadmill and get this guy off the machine. There's also possibility that a doctor might be, just chatting on his mobile phone or might be checking out his Facebook account or Instagram account, and this guy continues to walk, or your technician is doing the same thing. If the person is getting this finding and still you don't stop the treadmill, the person can develop a myocardial infarction. In fact, textbook says that there can be 1 fatal coronary event, that is MI, per every 10,000 treadmill tests. I repeat the fact once again, guys. During diagnosis, a person can die, which is really gonna be unfortunate. So please be always on the lookout. And if a person walking on the treadmill says even once, sir, I'm feeling uncomfortable, don't wait for him to say I'm having chest pain. If somebody says I'm having uncomfortable sensation, heaviness in my chest, reduce the speed, get him off the machine. It is better to be safe than sorry. Obviously, for diagnostic purposes, you can't let somebody die. I said 1 death can occur for every 10,000 treadmill tests. My objective is not to scare you. My objective is to ensure that you are more vigilant, because you as doctors have to ensure the fact that when you're doing diagnosis of somebody, the basic essence of medical science is first to no harm. I mean, during diagnosis, we cannot ensure somebody sustains a severe harm. This test is a very attractive test and can help us in diagnosis of chronic stable angina per se. And well, how does a downsloping ST segment depression look like? So I'm just going to sketch that before you, and I would like you to specially draw this with me so that you can feel relatively more comfortable. You can see the T wave coming up. Subsequently, you can see the downslope present here. This is the downslope that I'm talking about. In fact, in the exam, there's also a possibility that sometimes if they give you an image-based question, the ST segment depression may not be downsloping, but it might be horizontal. Even that is valid. I said it is rather downsloping that gives more credibility to the diagnosis. So I have shown 2 types of ST segment depression before you. One that I've shown is downsloping and the second one that I've shown is horizontal. Either of the 2 should be present, but it should not say upsloping. Because lots of time, now what I'm saying next is just for your general information, no point of noting down upsloping. My point is lots of time, if the air conditioning is not working properly, especially in a hot Indian summer, there could be sweat on the chest. and the sweat can contribute to poor contact of the electrodes with the chest. So lots of time due to sweat per se, there can be upsloping ST segment depression. I said upsloping ST segment depression. The technical word is downsloping / horizontal ST segment depression. What should be minimum value? 1 millimeter. How much would it last for? 2 small squares in the ECG. Where should it be present? 2 contiguous leads. That means that you need to get this guy off the machine. If he continues to walk on the machine, he can actually expire, and that would be gross medical negligence on your part. The sensitivity of this test will hover something in the range of approximately 75%. So yeah, theoretically it looks like a very good test to pick up, stress being given and then evaluation of blockages in the artery, and this is a non-invasive test, so obviously a good one, but the sensitivity is something in the range of 75% only. So we need to always look out for tests that will be having a higher diagnostic accuracy. Now this test obviously cannot be done on somebody who's on a wheelchair. I mean, let us assume if somebody is paraplegic, then a person cannot be expected to walk on a treadmill. Or I create another scenario for you. He is a patient of Burgess disease, thromboangiitis obliterans. He is having intermittent claudication. He walks for few meters, he develops calf pain, he develops severe pain in his toes. In those circumstances, he cannot be expected to walk continuously for the duration that we specify till we get a target heart rate. Similarly, if I'm having a diabetic patient, and this diabetic patient's HB1C is 12%, he's having a non-healing ulcer on the sole of the foot. You are very well aware that when it comes to neuropathic ulcer, it would either be on the heel or it would be at the metatarsal heads in a person. And in those circumstances, again, walking on the treadmill will not be advised. My next patient is again a diabetic, and he has neglected his HB1C values to the level that he has developed Charcot joints. Well, what are Charcot joints? Charcot joints are painless, paralyzed joints. But what I'm trying to say is there's a deformity in the foot of the person, and due to deformity, there's a tendency, or rather, there's a probability of falling, and that might cause even a head injury in a person. So some of the contraindications for treadmill test that I'm teaching you at the moment are very obvious, and you don't need to put any special effort to note them down or remember them. Because see, if somebody is having problem with the sole of the foot, problem with the stability of the ankle joint, problem with stability of the knee joint, like let me say a person is having severe osteoarthritis, so bad that even going to the bathroom is not possible. This is a obese lady, for example. She's having so much of pain in her knees that she can't even go to the bathroom, and you told her, ma'am, you need a total knee replacement. Now imagine if a lady having severe osteoarthritis requiring a total knee replacement is expected to walk on a treadmill, she won't be able to sustain the effort. Similarly, if a person is having severe variety of valvular aortic stenosis, you can remember from your basic classes that the orifice of the normal aortic valve is 2.5 square centimeter or more. But if a person is having severe variety of valvular aortic stenosis, that means orifice size will be less than 1 square centimeter, and less than 1 square centimeter cannot be expected to walk on the treadmill. In a sense that the cardiac output will be substantially reduced. You see the connection between the left ventricle and aorta substantially narrowed. Similarly, I'm giving a patient who's so fat that though he's motivated enough to walk on the treadmill, but your manufacturer guidelines say that, somebody with a weight of more than 125, 130, if he tries to walk on the treadmill, he will destroy the belt of the treadmill. I mean, this guy, morbid obesity, even if he's motivated enough to walk on the treadmill, he says, no, sir, I will walk. You won't let a very fat guy walk on the treadmill because he can destroy your equipment. The message is, if somebody is having plain obesity, yes, obesity can definitely be a situation where I can make a person walk on the treadmill, but not morbid obesity. Similarly, if I remove the word severe from here, I'm just erasing this word for a second. All I'm saying is, suppose it is written aortic stenosis of the mild variety, moderate variety, then there is absolutely no problem. Mild to moderate aortic stenosis will not cause severe limitation of, I would say, cardiac output, but in severe variety of aortic stenosis, there will definitely be a substantial reduction in the cardiac output to the level that syncope can develop, a head injury can occur. My next patient is having chest pain at rest. This person is having unstable angina. We are using a test for diagnosis of chronic stable angina. Unstable angina is chest pain at rest. I mean, how to remember it? I can just say, if somebody is having chest pain at rest, you as a doctor will not be so heartless that you'll say, okay, get up, walk on the treadmill. Unstable angina is a contraindication. So is a case of MI in the first 48 hours. I mean, let him rest, let him recover. Out of all the contraindications that I've explained to you for treadmill test, the most important one that I want you to remember is severe variety of aortic stenosis. Guys, all of these are contraindications for TMT. You don't need to put a special effort to remember them, because as I explained, if somebody is having problem with their ankle joint stability, knee joint stability, problem with the sole of the foot, some of the aspects are very, very straightforward. So at least two that I want you to remember are severe aortic stenosis and morbid obesity. And the way I've written it, I mean, severe aortic stenosis is going to be answered as absolute contraindication. Obviously, all of these are contraindications, but if they ask you to select the worst out of these, if they ask you to select one of these, then the one that you will always select in the exam would be severe aortic stenosis is an absolute contraindication for treadmill test. And well, once the printout of the report will come, it will also mention regarding a score. Now we will now study regarding a score which is called as Duke score. I want to remind you that we study about Duke's criteria. Remember, Duke's criteria are useful for diagnosis of infective endocarditis, but in treadmill test, using the Bruce protocol, we generate what is called as Duke score, and this is itself an MCQ, guys. I mean, I'm telling you the formula also. But in the exam, I don't think so he will ask you the formula. He will simply ask you what is Duke score used for. Your answer will be Duke score is used to evaluate severity of chronic stable angina. I mean, we will decide on the basis of Duke score whether a person will require bypass grafting, whether person will require stenting of the coronary artery, or whether it's gonna be only medical treatment. So Duke score goes like this: number of minutes walked on the treadmill. It could be maybe 8 minutes, maybe 9 minutes, depending on the individual capacity of an individual. And per se, like lot of people in India have a sedentary lifestyle, so they may not be able to walk even 8 minutes for so that matter of fact. From this, the software will automatically calculate 5 times the magnitude of ST segment depression. ST segment depression can be 0.5 millimeter, 1 millimeter, 2 millimeter, depending on the severity of blockages in the artery. From this, the software will further subtract -4 times the angina grade. Now, what I mean by angina grade can be limiting angina, or I would say non-limiting angina. What I mean by limiting angina is that he walks few meters, he has chest pain. Going to bathroom causes chest pain. Climbing one flight of stairs chest causes chest pain. So in those circumstances, if there is a limitation of physical activity like climbing stairs, going to bathroom, I will call it limiting angina. That is given a score of 2. If it is non-limiting angina, like he can go about his daily activity without any hindrance, then it is a score of 1. I am not writing angina grade per se because that's not usually asked, but I definitely want you to be sensitized to the fact that the Duke score value will determine the prognosis of the patient. Now suppose the value comes as more than 5, then you will say that this is a low risk patient and the chances of him dying in the next 10 years are very, very negligible. In this person, it will be advised medical treatment for chronic stable angina. But if the value of Duke score comes anywhere between +4 to -10, then I will say that he's having an intermediate risk of dying because of chronic stable angina or heart disease per se. So in these patients, we will do this procedure of putting a stent in the coronary artery. Like in Saurabh Ganguly's case, no, it was detected that he was having multiple blockages in single artery only. So they had to be a stent placed. So the message is that drug-eluting stent will be deployed in people with a Duke score value of what I have written before you. On the other hand, if the score of the person is going to be less than -11, then this would be a high risk person. This person can develop myocardial infarction any day. Therefore, all of these high-risk patients will be subjected to coronary artery bypass grafting. What you've learned at the moment is that Duke's criteria is for infective endocarditis, but Duke's score is not only going to help you diagnose whether somebody is having a blockages in the coronary artery or not, it is always going to help you prognostify. It will also help you to decide the treatment intervention required for a person. Score of more than +5, medical treatment. Score of -11 or lesser, a CABG, a coronary artery bypass grafting required for the person. So there is no need for you to cram the formula per se. It is just that I wanted to sensitize you to this fact that what is Duke score used for? It is used to decide what treatment is required. It is used to prognostify. It is used to identify the severity of blockages in the artery. Because if it is going to be triple vessel disease, then obviously the capacity of the individual to do routine tasks would be compromised. So therefore, coronary artery bypass grafting will be recommended for the person. But lots of time he might actually deliberately himself introduce a contraindication by saying that a very fat guy, he might not use the word morbid obesity. He might just say a very fat individual with a height of this much, weight of this much has come into your clinic, and he says that doctor, earlier, very fat guy complaining, earlier I used to have breathlessness on walking fast, but now I even have chest pain on climbing one flight of stairs. So doctor, I decided to come over for you for an evaluation. And the moment you read this question, because he has described a scenario morbid obesity, he will give you obviously the weight and height because he expects you to calculate body mass index. If the body mass index is going to be more than 40, that is morbid obesity, in those circumstances you are not going to advise a treadmill test in the person, but you will have to advise a test where you will not make the person undergo physical stress but undergo pharmacological stress. And what is the test known as, guys? That is called as stress echocardiography. So on my subsequent slide, I will explain to you what I mean by stress echocardiography and how are you going to do a stress echocardiography to identify whether a person is or is not having blockages in the artery. At this juncture, I also want to make it clear to you that the best way, the sure shot method of detecting number of blockages, site of blockages, percentage of blockages is coronary angiography. I mean, if I was given an opportunity to diagnose chronic stable angina, the test that will be having 100% accuracy will be obviously a coronary angiography. But as you can understand, the practical issue is when you're going to tell somebody, I'm going to take a transradial approach, femoral approach, the person is going to run away. So our objective is not to straight away talk about invasive tests. In the exam, you will first talk about, and in clinical practice also, you will first talk about non-invasive tests by which you can identify the blockages in the coronary artery. And the first test I have already explained to use, treadmill test. I've talked about contraindications for it. But if he deliberately introduce a contraindication in the exam by himself, then the answer that you will give for such a scenario will be stress echocardiography, and pharmacological stress will be given to the patient instead of making him walk on the treadmill per se. Now, as I explained, in a person who's morbidly obese and is having chronic stable angina, the first investigation to be done is obviously not treadmill test. Your answer would be given as stress echocardiography, and the pharmacological stress would be given using dobutamine. As you're aware from pharmacology, when I will start a dobutamine drip in this person, it will activate the beta 1 receptors, and that will result in increase in heart rate. If you increase the heart rate, it will cause increase in oxygen consumption of the heart. If the coronary arteries are of normal caliber, like if in you and me this drip is started, it will not cause any changes in the ECG because the supply of oxygen will be very much normal. But in a person who's having a genuine blockage, more than 70% in any one of the coronary artery, when you start this drip, after few seconds or maybe a minute, you will notice that the ECG of this person will start showing ST segment depression. The heart rate is going up and the ECG is showing a ST depression. The magnitude of ST depression should remain the same. It should be at least 1 millimeter. It should be persisting for at least 2 small squares in the ECG, that is 80 milliseconds. So lots of time you will read the word ST80 positive. When you read the word ST80 positive, it means right from the J point. J point is the isoelectric point. From that point, there should be a ST segment depression. This should always be present in 2 contiguous leads. What I imply by 2 contiguous is that it could be like, for example, V1, V2 or V3, V4 or V5, V6. And I also want to highlight that ideally it should be a downsloping or a horizontal, but not a upsloping ST segment depression. Mostly in the exam, he will be unlikely to be asking about the magnitude of ST segment depression. He might just use the word ST segment depression in a person in a treadmill test or on a stress echocardiography. And I will also be doing a echo in this person both when the drip is running and the drip has been switched off. When you will do echocardiography in this person, because there's a blockage in any one coronary artery, let me say right coronary artery, then right ventricle contractility, right ventricle function will be hampered. So he will always use the word regional hypokinesia. I repeat once again, the contractility of the heart is hampered because the blood supply to it is reduced. So echocardiography finding will be regional hypokinesia. And the message is that because you're using two investigations here, you're using ECG also and you're using echocardiography also. So if you compare the sensitivity of a stress echocardiography with respect to a treadmill test, the sensitivity is relatively better. It goes up to 80%. At this junction, I want to highlight that in lot of multiple choice questions, the current topic that we're studying, chronic stable angina, may not be written as chronic stable angina, may be written as reversible ischemia. In fact, at this junction, I want to introduce a new term. This term, which is very extensively used in MCQs, is an alternative terminology, hibernating myocardium. Well, how to understand and remember it? You see, you all have been biology students, so you very well know like polar bear hibernates in winter season. Why? Because availability of food is less. Therefore, the polar bear will try to cut down on energy expenditure per se. So when I say heart is not getting sufficient amount of oxygen, it is also exhibiting less contractility. You see, a few moments earlier, I taught you the term regional hypokinesia because there was shortage of oxygen supply, there was shortage of food, there was shortage of nutrition. So the heart is trying to conserve energy by limiting the amount of contractility that it is doing. So similarly, like I can draw parallels with a polar bear. The polar bear in a winter season is trying to cut down on the energy expenditure by reducing its physical activity. So hibernating myocardium is an alternative terminology for chronic stable angina, and lots of time you will also read a term stunned myocardium. Whenever you read the word stunned myocardium, it means sudden decrease in contractility of the heart. Stunned myocardium is a term that is used for myocardial infarction by a lot of examiners. The stunned implies sudden, so that's going to be sudden drop in contractility, MI. Hibernating myocardium, a gradual decrease in activity, that's due to blockages in the coronary artery. That's an alternative terminology that may be mentioned. So he might actually just say hibernating myocardium can be evaluated by, I have taught you two investigations till now, a treadmill test, and I've also talked about a stress echocardiography in the form of this case where I described a relatively fat guy coming to you with symptoms of chronic stable angina, and you gave pharmacological stress to this person. Over and above this, I also want to say that nowadays the advent of nuclear medicine, or I would say the scope of nuclear medicine, has dramatically improved. So we will also be using technology to identify blockages in the coronary artery in a non-invasive fashion, because if I want to do a coronary angiography, great. I mean, that's the best way. I mean, when I'm comparing here, when I'm giving you percentages, 75% sensitivity, 80% sensitivity, the gold standard against which it is being compared is coronary angiography per se. Now I will talk about couple of imaging tests which are available. So lots of time you will read the term MPI, that is myocardial perfusion imaging. And for this, I would like to highlight that if a person is having a fixed stenotic obstruction caused by an atherosclerotic plaque, like at the moment I've shown a 70, I can increase it to 80%, maybe 90% blockage in any one of the coronary artery, and the lesion is increasing on a daily basis because this guy is continuing to smoke, he's daily eating trans fats, so the lesion is a progressive one. Well, wherever there's going to be a physical obstruction present, the amount of blood that will go across this physical obstruction will definitely be limited. If you compare the magnitude of flow at point number A versus point number B, there's definitely a differential present. So what we are going to use here is a gamma camera that will scan the heart of this person and will pick up the differential flow, because you are going to give a radioactive, either we can use thallium-201 or we can use technetium-99. So thallium-201 will either be used, or we can give technetium-99, and obviously stress will be given pharmacologically to the patient, or he can walk on the treadmill also. But what I'm trying to say here is that if you are going to use these nuclear scans, obviously you can be having a relatively better diagnostic yield, and lots of time in multiple choice questions the terms used will be either thallium scan or it will be system-EB scan. Thallium scan is obviously for thallium-201. The term system-EB scan is also mentioned in endocrinology. I would like to remind you that system-EB scan will also be discussed in identification of a parathyroid adenoma. In the topic of hyperparathyroidism, I have talked about system-EB scan. So you will read about this scan two times, one in cardiology to pick up blockages in the artery, second time in endocrinology for identification of a parathyroid adenoma. And obviously because we are using a sophisticated software here, we are using technology to our advantage. So the sensitivity will obviously go much higher, and the diagnostic accuracy with myocardial perfusion imaging with either of the two, whether it is thallium scan written, whether it is system-EB scan written, goes up to 90%. So on a comparison basis in a multiple choice question, if they ask you to choose between the three that I've said, a treadmill test versus a stress echo versus myocardial perfusion imaging / system-EB scan, you will select system-EB scan as an answer. However, lots of time in multiple choice question, he might just try to play a trick on your mind by actually asking you to compare hibernating myocardium versus the scar. Now let me explain this term hibernating myocardium once again and then compare it with a scar. You can very well understand scar would mean that it is dead tissue, like a person had myocardial infarction last year and the area where the infarction occurred, there would be dead tissue, that would be a scar would have formed in that area. If there's gonna be a scar anywhere in the heart, whether it be left ventricle, whether it be right ventricle, anteriorly, posteriorly, scar is also going to exhibit less contractility because there is no live tissue. But hibernating myocardium, because it is having less supply of oxygen, there is a decreased contractility. I said the common thing between the two is, if some part of the heart is exhibiting less contractility, there can be two reasons for it. Less contractility can either be due to less supply of oxygen, or it could be due to a scar, which is dead tissue. Now, how do you differentiate whether it's a scar in the heart contributing to less contractility, whether it is going to be deficiency of oxygen? So we have another investigation available, that is a PET scan. You see, the logic is, in PET scan we are using radioactive glucose. Scar will not have any glucose uptake because it is dead tissue, but hibernating myocardium, it will obviously have some sugar uptake. It will be lesser. It will not be normal. It will be lesser because obviously there's blockages in the coronary artery. But when it comes to a scar, the scar will have absolutely no uptake. So what he did in the exam was, once he simply asked that a person on evaluation has been found to be having less contractility of some part of the heart, that is regional hypokinesia. How do you differentiate whether this regional hypokinesia is due to dead tissue, that is scar, wherever there's dead tissue, ultimately scar will form. So how do you differentiate scar versus hibernating myocardium? The answer is a PET scan. Let me just rearrange the information for you once again so that this becomes a permanent memory. I mean, this is what I have said. If the question simply talks about how do you pick up blockages in the coronary artery, the first test to be done in a person is treadmill test. But you will obviously be on a lookout for whether in the question has he put any contraindication to treadmill test. There could be problem with the ankle joint, knee joint, sole of the foot. There could be Burgess disease, peripheral arterial disease present in a person, severe aortic stenosis, all the contraindications that I explained. So in those circumstances, no problems. We will not give physical stress. We will give pharmacological stress using stress echocardiography. Suppose he makes you compare between treadmill test versus stress echo versus a system AB scan, then as I've highlighted or explained to you, the diagnostic sensitivity will increase with more usage of technology. But over and above this, I have also taught you another investigation, that is PET. Now, normally we study about PET scan in surgery for distant metastasis, but I have taught you a very interesting fact. There are two reasons why contractility of the myocardium will be lesser. One is it is having less supply of oxygen, that is due to narrowing of the coronary artery. We call it hibernating myocardium. We call it reversible ischemia. We call it chronic stable angina. The bottom line is there is narrowing more than 70% critical for a person to get symptomatic. And if there's going to be dead tissue in the heart due to MI which occurred last year or last to last year, yes, a PET scan can definitely help you in evaluating. However, if he just says the word, what is the gold standard test which will help you in evaluating this particular patient, then your answer would be given as coronary angiography. The approach that we can use is either a transradial approach or we can use a transfemoral approach. This is real-time evidence. This will tell you exactly where is the blockage present, what is the percentage of blockage. You can identify triple vessel disease versus a single vessel disease by coronary angiography. But since it is invasive, because it is highly accurate, that is fine. But because it is invasive, the acceptability of this to the patient might be lesser, which is why in the initial consultation we don't talk about angiography and we rather talk about the investigations that I have explained. Now I will explain to you what is the drug treatment which is to be offered for the person, and I give you an opportunity here to test your pharmacology also. What is the drug of choice for hibernating myocardium? What is the drug of choice for chronic stable angina? I'll give you a minute for you to think about it while I continue with the discussion. You see, one of the important mortality reducing medication that must be introduced in all patients of chronic stable angina to prevent future MI episodes is aspirin. The dose of aspirin that I'll be using here will be 75 milligram. I would obviously be recommending a enteric coated aspirin to reduce the chances of GI irritation and then development of maybe peptic ulcer disease. So this baby aspirin will be continued on a lifelong basis. Some people are not able to tolerate even the enteric coated aspirin. So instead of this, I can introduce Plavix, that is clopidogrel. Either of the two should be introduced, not both of them. I want to highlight, either you use aspirin 75 milligram or you use clopidogrel 75 milligram, either of the two. I'm not talking about dual antiplatelet therapy. Dual antiplatelet therapy will also be discussed. Combination of the two, I'm talking about both of them being given. That will be one in a case of myocardial infarction, that is TMI or non-ST elevation MI. And second, we also give dual antiplatelet therapy in cases of transient ischemic attack. You will notice later on in the discussion me talking about the word DAPT, dual antiplatelet therapy, is useful in management of myocardial infarction. Dual antiplatelet therapy is also used in transient ischemic attack to prevent the development of stroke. But here either of the two will be used to reduce the mortality. Now, I've given you sufficient time to ask you what is the drug of choice for chronic stable angina. And the bottom line is that this drug that I'm going to mention has been shown to reduce mortality. And when the answer will be a simple and a straightforward beta blocker, we have been using for a very long duration metoprolol, or we have newer derivatives like carvedilol available. But the objective is that when we will give metoprolol to the patient, it will reduce the heart rate. It will reduce the oxygen consumption of the heart. And if you downgrade the oxygen consumption per se, you will definitely be able to enhance the productivity of the heart per se. So metoprolol and aspirin both are mortality reducing drugs, but on a comparison basis, if he says the word, and mark my words there, if he says what is the major mortality reducing drug in chronic stable angina, your answer would be given as beta blockers, that is metoprolol. And I will also tell this person to always keep with himself the short acting form of nitrate, that is sublingual nitroglycerin. I'll tell him, sir, if you ever have episode of chest pain, like he's driving the car fast, somebody overtook his car, and like in India, road rage is so common, no? Suddenly somebody will overtake your car the wrong way, you might get angry. You and me getting angry is different because we don't have problems with our coronary arteries, but a guy with a 70, 80, 90% blockage in the artery, if he starts getting angry, starts swearing, etc., picks up a fight with a random stranger, the coronary ischemia that will occur, because if you're angry and you try to be physical with somebody, you need obviously energy, you need oxygen supply in the heart. This guy can develop chest pain. So in this guy, one, I'll obviously tell him, sir, you need to control your temper, don't get into road rage, don't get into fights with people. That's obviously a sane advice. But if he develops chest pain, then for emergency usage, he always needs to have in his car or the glove compartment of his car sublingual nitroglycerin. He can keep the tablet under the tongue so that the chest pain will ease off. And once he feels better, then he can obviously call medical services, or if he's okay, he can drive back home also. Now, lots of time this sublingual nitroglycerin bottle, because it's a glass bottle, the glass bottle can break also. So if I think that the person can actually, not be very responsible and the glass bottle might break, or I can suggest a buccal spray of nitroglycerin. The advantage is obviously that it will cover more surface area, so the results can even be faster. And lots of time your patients might be having to go on business meetings. Like this guy is 60 years of age, maybe has a company of his own and he's not retired. He says, sir, I have a company of my own in multiple cities. I need to fly regularly. So I'll tell him that, okay, you can also keep a transdermal patch of nitroglycerin with you. Like, for example, he's traveling via Vistar or Indigo or whichever airlines. Now at 30,000 feet, obviously, if he starts having chest pain, the plane might take some time for emergency landing. And by that time, obviously, the condition of this guy can deteriorate. So I'll tell him, sir, always in your wallet, keep a transdermal patch of nitroglycerin, because you see all these bottles, etc., they might be put in the check-in luggage by the security people. So it's always a good idea for these people to keep a transdermal patch of nitroglycerin with them, especially when they're on a flight, so that they can just use it as and when it is required. And over and above this, I will also be advising long-acting nitrates. Now, obviously, the question is which person will be requiring long-acting nitrates in this case? That would be a patient who was having postprandial chest pain. Remember, I talked about chronic stable angina also having possibility of chest pain after eating food. Remember, chest pain after eating food is chronic stable angina, but abdominal pain after eating food on a regular basis can be mesenteric insufficiency. So the two obviously need to be read carefully in the question. Isosorbate mononitrate is to be taken on a regular basis. This will help this person eat relatively better. And then obviously I will introduce the major mortality reducing drug, that is metoprolol. That would be 25, 50 or sometimes even 100 milligram as well. And instead of metoprolol, you will also see a lot of physicians writing carvedilol. The advantage of carvedilol, from pharmacology is that it is both a alpha plus beta blocker. So if you counteract the alpha, then the vasoconstriction component in the body is reduced by a few notches, and therefore the performance of the heart will increase and the oxygen consumption. The heart has to work against a resistance. If you downgrade the resistance, the working of the heart will become relatively better. So either of the two drugs can be used, though he can talk about contraindications to these also. Now, contraindication to metoprolol and carvedilol is not asthma or COPD. That is contraindication for non-selective beta blocker propranolol. The contraindications for cardioselective beta blockers are like sick sinus syndrome, because that will cause bradycardia. Metoprolol can cause bradycardia. Or it could be like a person having various varieties of heart blocks. I want to repeat the fact once again that in pharmacology, they talk about stuff like propranolol, that is non-selective beta blocker, being contraindicated in a person of peripheral arterial disease or COPD or asthma patients. I understand all those aspects. I mean, that's okay from pharmacological domain, including diabetes mellitus. Well, in diabetes mellitus, why? Because it will mask the symptoms of hypoglycemia per se. The message is cardio-selective beta blockers are not going to be recommended if a person is having 6NS syndrome or heart blocks. So what is the alternative that I have? So I will write point number 4 again, but with a 4 dash to highlight that if a person cannot be prescribed metoprolol due to the contraindications I mentioned, then you can be using amlodipine in the person. Calcium channel blockers can also be used in patients of chronic stable angina, though obviously, I mean, on a comparison basis, you see, one of the problems with amlodipine is it can actually cause a reflex tachycardia. It might actually increase oxygen consumption as well, though in limited amounts. So this can be used. The word is can be used. Preferably will always be beta blockers wherever feasible. I mean, we will be more comfortable with beta blockers, and then we will also advise statins in our patient. I will be advising high intensity statin, that is either atorvastatin or rosuvastatin, that would be 40 milligram or 80 milligram in the person. And the advantage of these statins would be that they'll help in reducing the further incidence or development of coronary artery disease or future episode of myocardial infarction. If this guy is a smoker, I will obviously counsel him to kick the habit, kick the butt per se, because the more he will smoke, the atherosclerosis component will continue to increase. At this juncture, another question for pharmacology that you need to remember is that lots of time, people who are especially smokers might be having erectile dysfunction. And this guy might be using Viagra, that is sildenafil. Now, you cannot combine sildenafil with nitrates. Let us see why. Sildenafil per se is a phosphodiesterase 5 inhibitor. You all know that from pharmacology. And well, how does it work? It will act by increasing the amount of nitric oxide. And when nitric oxide increases, there is vasodilation. So there would be more blood supply to the penis. So he will be able to sustain an erection. Now, the point is, if you are going to give nitroglycerin in the same chap, the nitroglycerin acts how? It will further contribute to more nitric oxide in the body. Already there is more nitric oxide due to sildenafil, no? If he's gonna use nitrates as well, you are gonna cause a substantial increase in nitric oxide, and nitric oxide is a vasodilator. It can cause crashing of the blood pressure. I wanted you to remember that the two do not gel together. I'm just putting a cross over this to say that if sildenafil and nitrates are gonna be used together, then the value of nitric oxide can increase disproportionately with the action of both of the drugs, and therefore the BP can crash. So it's definitely not a good idea that the two drugs should definitely never be combined. And over and above this, from the Indian domain, I also want you to remember that since Indian patients have homocystinemia, which causes premature coronary artery disease. Remember, I gave example of Saurav Ganguly, right? So vitamin B6, B9, and B12 should definitely be used. And then we have some new drugs also available for management of chronic stable angina that you can read from pharmacology. One of the drugs that we can use is ranolazine, right? Another one is ivabradine. Ivabradine reduces the funny current and thereby conserves oxygen. Ivabradine is also used in chronic congestive heart failure. In fact, you will read about ivabradine even in medicine in chronic heart failure and at the moment for chronic stable angina. So these are a couple of newer drugs which are being useful. Not very new, I would say, but yeah, relatively newer ones, which I would like you to study from pharmacology also. Ranolazine, ivabradine, trimetazidine, and they can be introduced serially or subsequently once the person is not responding to the initial therapy. We go all out with the drugs initially for management. Straight away, we will not advise stenting. Straight away, we will not be advising the patient to undergo any kind of a procedure like coronary artery bypass grafting. It is medical therapy that would be recommended for the person at the moment. The message I wanted to give you was that there are multiple drugs which will reduce mortality in a person of chronic stable angina. Let us just list them down. Beta blockers have been substantially shown to reduce mortality. How? By decreasing the heart rate and decreasing oxygen consumption. Low dose aspirin will anyway reduce the chances of thrombus, because we spoke about vulnerable plaques initially, so they can definitely be a plaque fissure. I don't want a coronary event to occur. Statins will also help in reducing the progression of atherosclerosis. I'm not saying that statins will reverse the atherosclerosis, but at least the further progression of the disease can be substantially reduced. Now, the question was asked as all of the following, listen to the question carefully, all of the following drugs reduce mortality in chronic stable angina except. And the answer to that is nitroglycerin or nitrates per se. You see, in last so many years of nitrates usage, not a single study has shown mortality reduction. I want to highlight per se, nitrates are for symptomatic relief. That is okay. But do remember, nitrates have no mortality benefit when it comes to patients of chronic stable angina. We definitely have mortality benefit with respect to metoprolol. We have mortality reduction with aspirin, with statins definitely. And I've just put these vertical arrows here to say that if they ask you to select one, then metoprolol is the first answer. That is why it was mentioned as the drug of choice for patients of chronic stable angina. Obviously, all the interventions that we're doing here is to reduce the chances of mortality in an individual. Single best mortality reducing step is metoprolol, and no study has ever shown any kind of benefit with respect to nitrates. This is the initial approach that we will use in all patients. If there is a failure of medical therapy, that means that person could be having triple vessel disease. Imagine if LAD is also blocked, left circumflex artery is also blocked, right coronary artery is also blocked. If multiple blood vessels of the heart are getting blocked, then obviously medicines will not be able to show much benefit. That is when I will like to do a coronary angiography in a person and demonstrate on real-time evidence where is the blockage, what is the percentage of blockage, and depending upon how many blood vessels are involved, we can then strategize and decide the intervention for a person. At the moment, the message is for triple vessel disease, CABG, you all know that. But for single vessel disease and double vessel disease, it is PCIV stenting. I'll explain these concepts to you as well, but I just want to make it clear right away. If it is gonna be single vessel disease or double vessel disease, recommended is PCI, percutaneous coronary intervention with drug-induced, drug-eluting stent. I'll explain all these concepts to you, but once you know this baseline information is clear, then obviously the more technical information I can definitely jot down on the slide. And at the moment, I've just tried to explain to you what is the first line management for any patient of chronic stable angina. Next, I will create a clinical scenario for you where my patient unfortunately had not responded to medical therapy, and that could be primarily because the number of blockages might be more or the percentage of blockages could also be more. So, once I have a failure of medical therapy, you will also notice that the patient will be more receptive to you when it comes to invasive investigation, especially in the form of coronary angiography. The same patient who initially was literally refusing to undergo angiography because he thought that it is invasive, and anybody would be scared of a transradial or a transfemoral approach per se. But now my patient has become more receptive. Why? Because he's suffering at the moment. So I have decided to do a coronary angiography after taking a proper consent and explaining the procedure. And why is coronary angiography advantageous is because first it will give you a real-time evidence. See, all the investigations that I discussed earlier, like stress echocardiography, or let me say even a thallium scan, system UV scan, they are actually indirectly giving you evidence, but now you can in reality see on the monitor what is the number of blockages. You can not only check out the number, you can also check out the percentage of blockages. So most importantly, and you are having three inputs together, that is site plus number plus percentage of blockages. So if you add up all of this together, and then simultaneously I also said that this would be real time, and therefore this explains why I was initially saying that this is the best of the gold standard investigation per se. Now the approach that we will be using would be either transradial or a transfemoral, and the technique of puncture of the artery. Now mark my words there. One, I said was the approach. Second, what they asked in the exam was the technique of puncture of the artery is called as. So do remember this name, though this is taught even in surgery as well. I just want you to remember that Seldinger technique is used to take the vascular access. It could be either of the two arteries. And which one should we prefer? Well, it depends on case to case basis, but most patients will be more comfortable with a transradial approach as compared to transfemoral. One, I would put it like this, that the groin area will be relatively more sensitive, then hygiene issues can be there, the hematomas can be bigger, and there are a lot of other factors that can actually contribute to a hematoma formation, not only I would say the site per se. So there are two ways by which we can do it, but Seldinger technique will be universal for whether it is a transradial or a transfemoral approach. Now, how are we going to go towards the coronary arteries is obviously we are going to send up a guide wire retrogradely. That would be sent towards the heart. It will go in the arch of aorta, then will go to the root of the aorta, and root of the aorta is where the coronary arteries are originating from. In fact, I can put up an anatomy question before you here. The question said, what is the first branch of aorta? You see, one error of judgment can be that if you don't read the question carefully, you will read or come across in anatomy first branch of arch of aorta versus first branch of the aorta per se. So the first branch of aorta, as I think most of you would have correctly worked out by this time, is the coronary artery. But if I just modulate this question, As I said, first branch of arch of aorta, then it would be brachiocephalic trunk, because left side it would obviously be the left common carotid artery and the left subclavian artery, but it is the brachiocephalic trunk on the right hand side which would be the first branch of the arch of the aorta. And why I mentioned this is primarily to sensitize you to the fact that errors of judgment can occur while carelessly reading the questions, because few words will obviously make a lot of difference. And most importantly, since I want to access the coronary arteries of the patient, it has to be a retrograde approach, and on the monitor under fluoroscopic guidance I can see which blood vessel is being accessed. I repeat the fact once again, the advantage of coronary angiography is real-time evidence. You will be able to know three datas simultaneously: number of blockages, percentage of blockages, and the site of blockages. Percentage you anyway know will be more than the critical value 70%. That is when there would be symptoms occurring in a person. Now I'm going to create some further scenarios for you, in a sense that suppose he says person is having triple vessel disease, then he will ask you what is the best management of this person. Obviously medical therapy will continue, not even for a single day will we discontinue the medication. And if he has to undergo any kind of procedure, even if when he has to undergo, let me say, coronary artery bypass grafting, which is the treatment of choice for triple vessel disease as well, the person should continue with aspirin. The baby aspirin 75 milligram tablet that I was talking about is not to be stopped. You see, when I was a student at your age, I used to read that aspirin 75 milligrams should be stopped at least 7 days before any intervention. Then it was like 3 days before intervention, the 1 day before intervention. The current guidelines of American Heart Association is that whatever be the type of intervention you're doing in a person, when it comes to the 75 milligram aspirin tablet, if you stop it, the chances of intraoperative myocardial infarction, mark my words there, if you stop the baby aspirin in any known case of chronic stable angina, whatever procedure you are doing, there's a possibility. It could be something as simple as hernia repair that you could be doing. It could be even a hydrocele drainage that you might be taking care of under local anesthesia. My point is, if you are going to stop this baby tablet of aspirin, the chances of intraoperative myocardial infarction can increase dramatically. So the current guidelines are give it even on the day of the surgery. Now, once it comes to coronary artery bypass grafting, there are two aspects or domains that one should be familiar with. First, in triple vessel disease, even your patient will ask you, sir, what do you mean by the word triple vessel disease? So he will not obviously understand the anatomical terminologies, but this is how I will try to explain to the person. I will explain to this chap that the anterior, the part of your heart that is facing a sternum, is suffering from ischemia, because one of the main blood vessels of the anterior wall of the heart would be left anterior descending artery. Left circumflex artery, well, it will be supplying not only the lateral surface, but it will also go posteriorly and would be supplying some part of the posterior part of the heart as well. And right coronary artery will be supplying the right ventricle, and a chunk of that would be in fact responsible for forming the inferior surface. You see, right ventricle is not only present anteriorly, but it also forms the base of the heart, the inferior surface per se. So when you explain this even to a non-medico, that the front of your heart, the bottom of your heart, the base of your heart, the lateral wall of the heart, everywhere there is ischemia present, because you are having substantial blockages in each of these blood vessels. So obviously the medicines are not working. There has to be a reason behind it. The reason is multiple blockages of substantial nature contributing to severity of ischemia, which is beyond the level of what medicines can manage. So in this person, we will definitely have to go in for CABG, that is coronary artery bypass grafting. And now the question will be from the patient as well as from the examiner, what is the preferred bypass graft? Now, if you're working in a government hospital, lots of time you would have seen the saphenous vein being used. But I would say like this, that the performance of an arterial graft will always be superior to a venous graft. Why? Because arteries are used to a high pressure circulation. So on a comparison basis, when you do a head-on-head trial, the comparison basis will always show that internal memory artery grafts or radial artery grafts will be superior as compared to the vein. Then why vein is used? Well, I just want to say that that would be ease of harvesting the graft per se. You see, in a government hospital where there would be lesser number of facilities available, lesser number of CTVS surgeons available, CTVS guy would try to do more number of cases. So that means that he has to obviously reduce the operating time. And to reduce the operating time, if you have to harvest the saphenous vein, it is relatively easier. It takes lesser time as compared to harvesting, I would say, internal memory artery or the radial artery graft. So it is just the ease of or convenience part that is being looked upon. But on a comparison basis, when you will take up a patient who has, let me say, undergone a great saphenous vein by graft versus a person who's undergone an internal memory artery graft, then you will definitely notice that the patency rates will be different. What I'm saying next is just for your general information so that you are more comfortable about why am I, emphasizing on the fact that the artery is superior as compared to the vein. This comes from the following data. You see, if a person has undergone an internal mammary artery bypass grafting, then these bypass grafts can also get blocked. Please appreciate atherosclerosis is such a nasty disease that even in the graft that you put in the heart, they can also be affected by atherosclerosis and in time can get blocked. Studies have shown that if a person will undergo a coronary artery bypass grafting, he might have to undergo the same procedure again after 20 years because internal mammary artery grafts work flawlessly for that time. After that, a redo CABG might be required. In fact, just to make you more comfortable, I can give example of our former Prime Minister Manmohan Singh ji. Manmohan Singh ji, when he became Prime Minister, initially he underwent a CABG, then he had to undergo a CABG a second time. That's when the radial artery grafts were used in him. That was because the disease is relentless. The disease tends to progress in spite of, you see, I've talked about statins per se, but there's a limited efficacy with the drugs as of now. So patients might require a CABG again after a few years. Now, if you compare a person who's undergone a saphenous vein grafting, there is a distinct possibility that if somebody undergoes surgery and great saphenous vein graft is put in 2021, he might have to undergo the same procedure in 2031 also. The patency rate of the graft of the vein is 10 to 12 years and the artery is 15 to 20 years. Nobody will ask you in the exam the patency rates. That is just to sensitize you to the fact that why internal mammary artery or arterial grafts as such are superior as compared to venous grafts. So whenever he talks about the following term, he says, what is the revascularization procedure? He just wants to make it sound a little sophisticated. So the MCQ will say, what is the preferred revascularization procedure required for triple vessel disease patient? Your answer is coronary artery bypass grafting. But if the question is given as, what is the revascularization procedure required for single vessel disease, then the answer is slightly different. And now I want you to listen to what I say very carefully. You see, when I'm talking about single vessel disease in a patient, the treatment of choice at this point of time will be answered as PCI, percutaneous coronary intervention with stenting. I will talk about the type of stents also which are available as of now, but the message is revascularization procedure for triple vessel disease versus single vessel disease versus double vessel disease. Both in a MCQ single vessel disease as well as in a MCQ double vessel disease, your primary answer is percutaneous coronary intervention. I'm going to explain the procedure in a few seconds. With stenting is required for the person. Now, I want you to not note down any information at the moment. Just keep the pen aside and listen to the aspects that I say. You can imagine this to be the longitudinal section with respect to any one epicardial coronary artery. Let us take it to be right coronary artery. The point that I first want to highlight is that atherosclerotic plaque will contribute to a fixed obstruction because this obstruction will obviously keep on increasing with time. Now, as the obstruction will keep on increasing, initially it was 70% blockage, it can increase to 80%, 90%, 99%. You see, logically speaking, if somebody is having 99% blockage, should he be having chest pain on exercise or should he be having chest pain at rest? Logically, if somebody is having 99% blockage, he should be having chest pain at rest. But see what I taught you. I taught you always, and all through your medical college, you have been taught in chronic stable angina, the chest pain comes on exercise. So a patient can ask you, sir, you were telling me that my dad has a 90% blockage in the coronary artery. I exaggerated that to 99% blockage in the artery and still he's having chest pain, not at rest, but on exercise. He's asking you, sir, how is it possible? Well, guys, in patients of chronic stable angina, there's a good prognosis if it is a single vessel disease with, let me say, 99% blockage. Why? Because it's a very slowly progressive disease, and because it is very, very slowly progressive, that is why collaterals will be developing in this case, and these collaterals will definitely ensure the fact that at least some blood will be able to navigate across this physical obstruction. The message that I want to give here is that when it comes to single vessel disease occurring in a person, chronic stable angina overall will be said to be having a good prognosis. Now, you might be putting up a question here before me that, sir, on one hand, you're saying person is suffering, then you're saying good prognosis. Sir, I'm saying good prognosis because at least he's not dying. He's suffering, I agree, but at least he's not dying because the collaterals are ensuring a flow across this physical obstruction. So patients of chronic stable angina are said to be having a good prognosis. It's a reversible ischemia and there are collaterals. So even if there's a 100% blockage, it is unlikely the guy will die because this occurs very slowly. So time will be there for the collaterals to develop. Now what I have done in my patient is taken a vascular access. Hypothetically, I'm saying I took a femoral access in the patient. From the femoral access, I will go retrogradely towards the iliac artery, I'll go inferly into the aorta, and then we go into the arch of the aorta per se, and then into the root of the aorta, and that is where the coronary arteries will be originating from. So I am gonna send up a guide wire in a retrograde fashion, and under fluoroscopic monitoring I can definitely see the guide wire across. So let us assume this black line to be the guide wire in place in the at the site where the fixed obstruction is present. Once the guide wire is at the correct site, then we are gonna deploy a balloon over this. Now you don't need to draw this, just follow what I'm saying. This will be a steel wire reinforced balloon that might be inflated with a pressure as high as 18,000 millimeter of mercury. And the moment I deploy this steel wire reinforced balloon, the pressure generated by this balloon will physically destroy this atherosclerotic plaque. So, though this balloon will be deployed only for a fraction of a second, but that fraction of a second, the pressure generated will be sufficient to destroy this atherosclerotic plaque. So, I will just remodulate this diagram once again. Now, the balloon is being deflated, but the force generated by the balloon per se has resulted in physical destruction of this atherosclerotic plaque. And therefore, the good news here is that, well, there is definitely a destruction. There's some debris present, obviously, because the balloon has deployed some force, but as such, the physical obstruction that is present has been removed. So the good news is that I have been able to physically deploy a balloon here, get rid of the obstruction, which was the problem maker for the patient. But the bad news is the debris which is generated is going to be a troublemaker. Why? Because platelets are attracted to anything foreign in the blood vessel. So the moment there would be debris generation here, there would be a formation of a platelet plug. At the moment there's a platelet plug formation, then in those circumstances there could be a clot formation, thrombus formation, and in fact on the table itself the person can develop a MI also. Now that's very bad news. On one hand, I was trying to cure the patient. Yeah, I did cure the patient in a sense that physical obstruction is gone. But the bad news is there's a MI on the table. This MI that develops on the table while the procedure is going on is a MCQ statement. And I just wanted to note down that if during PCI procedure, you need to note down the words during PCI procedure, if somebody will develop a MI on the table during the procedure, then we call it type 4A myocardial infarction. This is asked also because of the fact that the troponin I values will elevate substantially in this case. I want you to remember this MCQ statement of mine that there is a 5 times elevation. I've written the word 5x. There's a 5 times elevation of the value of troponin I over the baseline value. That's the normal value. Simply because there's a substantial amount of necrosis occurring in the patient. Now, because I know the fact that the PCI procedure can cause triggering of a MI, I will definitely use my knowledge of pharmacology. The doctor here will be using the knowledge of pharmacology to prevent this from happening. So let us now study what are the drugs which are used during the procedure, or rather before the procedure, to prevent the onset of myocardial infarction. Therefore, first of all, before the procedure is done, we will definitely like to put the patient on antiplatelet drugs. I'm not talking about aspirin anymore. Aspirin, obviously, he has been on aspirin for so long. I am at the moment talking about fast acting but relatively short duration antiplatelet drugs. So patients who are gonna undergo a PCI procedure can be started on any of the following drugs. Usually it is ticagrelor, it can be prasugrel, or it could be ticlopidine. These are MCQs by themselves also for pharmacological domain that you need to remember, and you can study the pharmacology of these drugs by yourself from the pharmacological chapters per se. But I just want you to remember at the moment that these relatively fast acting, any of these can be used. Like usually it is ticagrelor that is used preoperatively to reduce the chances of MI on the table. Now, once the patient is being taken into the cath lab during the procedure, or I would say just before the procedure has started, we would also be giving to this patient enoxaparin, that is low molecular weight heparin, and this will again reduce the chances of clot formation per se. Over and above this, there will also be usage of drugs which are going to be specifically designed to reduce the chances of platelets causing triggering of a clot formation, because you see I said platelets are the troublemaker in this case. So additional drugs which can be used at this point of time are abciximab, though I will write some other molecules also. Most of the time it is abciximab that is used, or sometimes you might read about eptifibatide. You see, you visit any cardiology unit, they'll obviously be talking about these drugs like abciximab or eptifibatide or tirofiban. These molecules will rather hinder the interaction of platelets with the clotting cycle products, so that ultimately the interaction does not result in a thrombus formation. I'm just going to put some markings here to say that ticagrelor, enoxaparin, abciximab or eptifibatide, if they are used pre and intraoperatively, then you can definitely prevent type 4A myocardial infarction, but consent obviously has to be taken from the patient and the relatives as well. So you must explain this concept to the patient per se, that during the procedure he can develop MI. Patient is going to be very afraid of that, but you will tell him, sir, we have the technology, we have the knowledge to prevent this from happening. So now I'm going to remove this guide wire from the picture, and you can very well see that, well, the procedure has been completed. The patient is literally having a brand new coronary artery. I mean, this guy can now go bungee jumping, he can do rock climbing, all those activities which were a dream for this guy, because every time he used to do little bit of exercise, walking fast, he used to have chest pain. This guy can do any routine physical activity which a 20-year-old guy can do, because his coronary artery obstruction is physically gone. But now the problem is, atherosclerosis is such a nasty disease, guys, that it can come back at the same site. It can come back and it can physically block, or it can contribute to even, I would say, same amount of blockage after a few months. So because you know, atherosclerosis has a tendency to reoccur. Mark my words there, because atherosclerosis can reoccur at the same site, or maybe proximal or distal to this. I can prevent this from occurring by deploying a stent as well. So please remember, we are gonna deploy a stent in this case. Why? Because we wanna prevent the atherosclerotic physical blockage to come back again. We are in a preventive mode at the moment. The stent which is deployed in this case is most of the time referred in the textbook as drug-eluting stents. So in pharmacology, he can definitely ask you, what is the coating over the stent? I mean, we are deploying a stent here, so there must be a stent, or there must be a coating of medicine over the stent that will prevent this atherosclerosis from coming back. So we will be using drugs which are immunomodulatory in nature. The names would be like everolimus or sirolimus, or the oldest one, or the older generation were having even an anti-cancer drug, paclitaxel. So one, you need to remember this slide from the pharmacological domain. You can just take a picture of it at the moment, and you just need to refresh your knowledge of the drugs which are currently written on the slide per se from the pharmacological domain. From the medicine perspective, it is sufficient if you just remember two aspects. What is the treatment of choice for single and double vessel disease? PCI stenting. Second point you need to remember is, what is the type of MI that can be seen during the procedure per se? We're gonna call it a type 4 MI. How much is the type of elevation or the magnitude of elevation? Well, that would be 5 times elevation of troponin I that can occur. And yeah, I mean, if he wants to go into the pharmacological domain, he can definitely talk about it. And I've highlighted the fact, why are you putting stents, is because you want to prevent the atherosclerotic plaques from coming back. I will now create a scenario for you where the patient will be having a double vessel disease, but it would be multi-site obstruction. Let me just sketch this before you. You can take this as representation of, let me say, the right coronary artery and the left circumflex artery. In the right coronary artery of the patient, there are two different obstructions. One is, let me say, 70%, and the second one is a little more, let me say, increase it up to 80%. And in the left circumflex artery, I have shown multiple lesions present about 2 to 2.5 centimeters apart, but you can see that they are having a variable obstruction, in a sense that one of them I can increase up to critically 90%, one of them I can say is hardly 30-40%. But my point here is that if a person is suffering from a double vessel disease but it is a multi-site obstruction, then one, I can obviously go for PCI stenting, but I will have to deploy 5 stents in this case, and you can very well appreciate the cost of the procedure will go up. You see, whenever we do a medical procedure, we not only have to take into consideration its efficacy, but we also need to look at the cost benefit ratio to the patient. So in this particular scenario, I would like you to remember that the treatment of choice should be answered as coronary artery bypass grafting. Though I can say that in corrupt practice, people might be putting multiple stents even in a case like this, but since we are here to study ethics and not the wrong practice, so the statement of mine that I want you to remember at this junction is double vessel disease with multi-site obstruction per se. The treatment of choice that would be recommended would be CABG, coronary artery bypass grafting. So now we have two indications for CABG, as you can recall from the previous slide: triple vessel disease and double vessel disease with a multi-site obstruction. Now, there's a very peculiar question that I want you to remember, and I would say full attention at this particular statement that I make. If you read a question that is talking about LAD blockage, then LAD blockage is obviously single vessel disease, and I've taught you the treatment of choice for single vessel disease is PCI stenting. But if you read a question that begins like this, LAD blockage, and then says that the ejection fraction is less than 40%, one, I want to highlight at this particular point of time that LAD is too precious a blood vessel to be handled with respect to PCI stenting, because it's a very precious blood vessel and the cardiac output of the patient is getting compromised. He's having a low ejection fraction. It would be better if we treat this guy even with the coronary artery bypass grafting. I want to highlight the fact that if there is any other blood vessel written in the MCQ except LAD, like suppose there was a question that is talking about a single vessel disease with respect to right coronary artery blockage, or let me say left circumflex artery blockage, it's a single vessel disease. Even if it talks about lower side of ejection fraction, still the answer is PCA stenting. But this particular blood vessel that I've highlighted, LAD, I mean, this is too precious a blood vessel to be handled only with PCA stenting. I would be more comfortable if this person straight away agrees for coronary artery bypass grafting. So we can just summarize the indications for CABG: triple vessel disease, double vessel disease with multi-site obstruction, and the most important one, I mean, this is an important statement that I want you to remember, LAD blockage. Why? Because when you read it casually, no, it will look like single vessel disease, so you might be tempted to answer as PCI stenting. But since I've already sensitized you, you have to remember this statement of mine. In case he is mentioning any other blood vessel apart from LAD, no issues, answer PCI stenting, but here the answer is coronary artery bypass grafting. These are the revascularization procedures that would be done in the patient. So let us just make a list of some important aspects that you need to remember for the topic of chronic stable angina. The alternative name for it, most examiners will rather use the word hibernating myocardium, and I want to remind you that whenever you read the word stunned myocardium, then stunned begins with alphabet S. That is, you can remember it, it's a hack obviously, that there's a sudden decrease in contractility with respect to myocardial infarction. Now, this condition that I am discussing at the moment will be having at least more than 70% blockage to cause symptoms to occur in a person. But when it comes to biomarkers will always be normal in a question of chronic stable angina. Why biomarkers are normal is because there's no necrosis, it's only a ischemia that is present. So what is the first investigation that is required in this chap? It's a treadmill test showing a ST80 positivity, that is ST depression of more than 1 millimeter persisting for at least 80 milliseconds starting from the J point, and should be in contiguous leads, that is minimum of 2. But suppose in the exam he creates a scenario for you that the person is unable to walk. It could be severe bilateral osteoarthritis of the knees. It could be possibility of a non-healing ulcer in the sole of the foot. Well, what you can do in this patient is maybe give pharmacological stress. So therefore the investigation of choice will then change over to stress echocardiography. So don't be under impression that all questions will have answers at treadmill test. That depends on the circumstances that are asked in the exam. However, if he wants to talk about a person having decreased contractility in some part of the heart on echo, now there can be two reasons why the contractility can be less. One can be that he had a MI maybe 1 year back, and wherever the MI episode occurred, there was a scar in the heart. Scar will obviously not contribute anything to cardiac contractility, so therefore the cardiac output would be less. And even in chronic stable angina, because oxygen supply is less, so the heart is trying to conserve oxygen and thereby reducing the power generation, power output. So if you have to differentiate between a scar versus a hibernating myocardium, the best bet that you have is a PET scan, primarily because you see scar will not have any metabolic uptake. Here we will be using 18-fluorodeoxyglucose. So per se scar does not have any uptake, whereas hibernating myocardium will at least be having some kind of uptake. However, sometimes he might actually talk about a nuclear scan that can be used to evaluate chronic stable angina. Then your answer would be given as system EB scan. The second time you will read about me talking about system EB scan would be in endocrinology with respect to localization of a parathyroid adenoma. Now, which is the major mortality reducing drug for this condition? Though there are multiple mortality reducing drugs for chronic stable angina ranging from aspirin to statins to beta blockers, but if you have to select one, then your answer should be given as beta blocker, and the one that we will prefer here is metoprolol, or we can be using carvedilol for the person as well. If he specifies what is the revascularization procedure required for the person, now that's one of the important things that I want you to remember, that whenever he's asking you about revascularization procedure, always have a look at what are the number of blockages or which are the blood vessels involved that he has told. There can obviously be two possibilities. Either the answer will be CABG or it will be percutaneous coronary intervention with drug-eluting stents, and the scenarios I've already explained to you. PCI stenting will be single vessel disease and double vessel disease. The moment the word double vessel disease with multi-site obstruction will come, the answer will change over to CABG. Triple vessel disease you already knew, and I also highlighted if it is LAD with a low ejection fraction, again CABG is to be done. If he just says what is the gold standard investigation to be done in these patients, that is coronary angiography, most patients will be initially a little apprehensive about any kind of a vascular procedure, so you may not get consent for this. But if the person does not show improvement from the medical perspective, yeah, he will be very much open, because he's suffering, so he will definitely require elevation, or he will ask you that, sir, what is going on? I'm taking the medicines on a regular basis, I quit smoking, I'm taking my hypertension medication regularly, but still, even if I stress out a bit, even if I try to just climb stairs fast, sometimes in an office meeting, if I'm late, I'm climbing stairs fast, I have this chest pain, so I want to get rid of it, doctor, do something. So in emergency scenario, obviously he can take a buccal spray of nitroglycerin, that would be goodbye to the pain, but he wants to prevent these episodes from occurring, and that is where the angiography component comes in, that it gives you real time evidence. You can physically see what is the number of blockage, percentage of blockage, site of blockage, and then decide on the treatment algorithm for the patient, which is revascularization procedure. I would like you to note down this information on a yellow stick-on pad, stick it out somewhere, and try to read this information for next couple of days every time you pass that stick-on pad, so that this becomes imprinted in your memory. Now my objective, why I have, I would say, once again highlighted about chronic stable angina at the end of this topic, is because I want you to compare this information of chronic stable angina with that of unstable angina that I will discuss next. And lots of time in multiple choice questions, instead of using the word unstable angina, he might even use the word accelerating angina. And don't be under impression that both cannot occur in a same patient. There is a possibility that a person was previously having chest pain on exercise, but now the same person will start experiencing chest pain at rest also. I said a very surprising thing. I said for last 6 months he has been having these episodes of chest pain, and he has been postponing going to the doctor. But now the same person is having chest pain at rest also. That is because of unstable angina component, and therefore sometimes the term used is accelerating angina. The word acceleration basically means earlier it was on exercise, but now it is present even at rest. So the severity of the disease has increased. Let us now try to understand what is the problem going on in unstable angina. In this slide, I'll talk about the pathogenesis of the disease, and then subsequently we'll talk about what will be the clinical presentation and what will be the workup of yours and the treatment of the patient per se. So once again, I have highlighted before you atherosclerotic plaque. This is where the fat is, this is where the foam cells are, this is where the modified macrophages loaded with the bad cholesterol are present, and superiorly I have shown is a fibrous cap. As I have highlighted a couple of times, atherosclerosis will be having two layers. Atherosclerotic lesions would be having a fibrous cap shown in blue, and then in yellow is the fat deposition present. And now when the blood is going through this artery at high pressure, unfortunately there's a crack which I'm going to call as a fissure. The moment the fissure will appear, there would be exposure of collagen, and collagen is a trigger for the platelet. So the black dots here represent the platelet plug getting formed. While I'm talking before you, this platelet plug then organizes to form a clot, and there's a thrombus developing in the lumen of the coronary artery of the patient. It just happened very fast. Let us just recall what is the problem going on here. The first thing that I said for this particular gentleman was development of a plaque fissure, and you can very well see that right in the beginning of our discussion I had spoken about vulnerable plaque and a non-vulnerable plaque, and also investigation for it, MDCT, multi-detector CT scan. Now my patient who was having this vulnerable plaque actually had never come to me for a visit. He will come now because of the chest pain at rest. So let us see what brought the patient to you. There was a plaque fissure. He's maybe sleeping in the night. There was a plaque fissure. There was definitely a platelet plug formation, and the platelets are attracted to collagen. I mean, that's the basic trigger, I would say, for why unstable angina would be occurring, and that's important. Why? Because we need to control the platelets from misbehaving. So I will teach you about some intravenous antiplatelet drugs that are useful for management of unstable angina. Now there's a thrombus which is developing in the artery, and as we are discussing this, the thrombus size is increasing. However, in human body, there's an anti-clotting system also. See, there's a balance, there's always a check, and you're familiar, the anti-clotting system will operate on protein C, protein S, and antithrombin 3. So as the clot is being formed, it is getting disintegrated also. So this is what I'm saying, guys. Let me say this is a epicardial coronary artery. I have shown very minimal blockage in the artery. The atherosclerotic plaque is very small. I'm not shown a 80-90% blockage like I was talking about earlier. This is a very minimal blockage present in the artery of the patient, and there's a thrombus which is getting formed here. It is increasing in size as we are discussing the topic, but then it is also getting broken into pieces. What is breaking up this clot? The fibrinolytic system of our body. The inbuilt fibrinolytic system operates on protein C, protein S, and antithrombin 3. This is breaking up this clot into fragments, and these fragments will then be distributed via the bloodstream to the distal circulation. So the epicardial coronary artery will now give rise to branches. These are the distal ultra small branches of the main coronary artery. These ultra small branches are called as perforators. See, coronary arteries are present at the outside of the heart, and they send branches deep into the muscle, and all these small fragments will go and will cause physical blockage of these ultra small blood vessels, causing called as perforators. And because of the, I would say, the physical blockage of the perforators, now the myocardium is suffering, and that is where the chest pain origin will occur in the person. If I am to write one single word that explains everything that is mentioned here, then I would suggest you to remember simply this word erythroembolism. And if you just get this word right, you will definitely remember the pathogenesis of the topic, that is unstable angina, or referred as accelerating angina, where in the person previously there was chest pain at rest, now chest pain episodes are occurring at rest. Why? Because it's not the main coronary artery that is blocked, it is the ultra small blood vessels, that is the perforators, which are affected. In fact, just to see that you and me are on the same frequency, I can just make a statement before you. If I do thrombolysis in this person, if I as a doctor is not able to identify this condition, and if I do thrombolysis in this guy, assuming it is MI, because MI will also have chest pain at rest, unstable angina will also have chest pain at rest. If I will do thrombolysis in this person, will it cause benefit? Or will it break this clot into further small pieces, and they will get distributed into the distal circulation, and it will worsen the patient? Well, you said right. It will worsen the patient. It will deteriorate the patient. Guys, unstable angina is a condition where thrombolysis is absolutely contraindicated. I've provided a reason to you why thrombolysis is contraindicated here, because already the clot is getting fragmented into pieces, and these distal small blood vessels are the ones which are the ones which are suffering. If I break the clot further into small pieces, I will have a shower of more emboli that can actually deteriorate this person. So one of the MCQ importance of this particular slide is what I've written right now. I mean, rest you can just skip. You can just remember the main word, that is one, erythroembolism from the pathogenesis perspective, and thrombolysis is absolutely contraindicated in these patients, and if done by mistake, obviously that's a medico-legal negligence. So let us now look at how the case would be given to you in the exam. In fact, when he will describe the case, he will deliberately try that you answer it as MI, but you need to pick it up from the ECG in the biomarkers primarily. So I will try to give a history which might initially look like myocardial infarction only. We have this elderly gentleman, male, as I have highlighted. I mean, men are more predisposed to coronary events as compared to women. Atherosclerotic risk factors are present. He's a cigarette smoker, does 2 packs of cigarette every day, is hypertensive as well. And unfortunately, he has been suffering from diffuse chest pain since morning. This chest pain could be present for a couple of minutes, or maybe depending on the pain tolerance of somebody, could be present for hours also. And when the pain became intolerable, like this old man, maybe he stays alone, so he called up his son and daughter. It took some time for them to drive to the residence of this old man, and he has been suffering for, let me say, 3 to 4 hours at the moment. Severe chest pain at rest, is all sweating profusely, is also feeling breathless, so dyspnea on exertion, etc. could be given in the question. The point is, whenever a question will deliberately describe Levine sign to you, the meaning of the word Levine sign is diffuse chest pain. Person will put his hand on his chest like this. You will obviously be tempted to think in terms of myocardial infarction, but then you will obviously have to look at the ECG findings in this particular case and compare it with MI. In unstable angina, ST is going to be normal in 50% cases. They can be ST depression in 25% cases. They can be only T wave inversion in 25% cases. I repeat that again. 50% cases ST normal. 50% cases ST is normal. 25% cases ST depression, or they could be 25% T wave inversion. So obviously ST elevation MI will never be picked up, or will never, you can never wrongly diagnose it as ST elevation MI. But there's a distinct possibility that you might be answering this as non-ST elevation myocardial infarction, because in non-ST elevation MI they can be ST depression and T wave inversion. So what is gonna tell you in the question that this particular patient is having unstable angina will be biomarkers. If you check out the biomarkers in this particular case, it's already been 3 hours. Usually troponin I tends to rise in myocardial infarction by 3 to 4 hours. In this case, the values of troponin I will be given to be normal. Yeah, they can be slightly elevated, but sometimes that slight elevation may not be picked up. The normal value troponin is 0.04 nanograms per deciliter. Now the point is, in this condition, it might be a slight elevation, but sometimes the slight elevation may not be picked up by the kits that we are using. So in lots of cases, the report will turn out to be normal. And now you will anyway have to treat this person. So let's look at the treatment of a person of unstable angina. There is no need for thrombolysis, as I've already explained to you. And in fact, that's a negligence if you are doing thrombolysis in this case. Now the mnemonic that I wanted to remember for the treatment of this guy is ABE-MOON. In ABE-MOON, alphabet A would stand for abciximab. This is gonna control the platelets from misbehaving. Obviously, as I've highlighted and you know from pharmacology, abciximab prevents the interaction of the platelets to result in ultimately a thrombus formation. And I will be using B, that is beta blocker, because that will reduce the oxygen consumption of the heart. So I can give IV metoprolol. Enoxaparin will again prevent the platelets from misbehaving. That's a low molecular weight heparin. The reason I'm giving morphine for this guy is, one, to control the chest pain component. Secondly, morphine reduces pulmonary edema. Lots of time in these patients, the cardiac contractility is hampered. So pulmonary edema component, which explains the breathlessness, would come up. Obviously, my nurse has given oxygen to the patient. It could be given with help of a nasal cannula or with help of a tight fitting face mask. Then we shall also be giving to this patient alphabet A, that is aspirin. Now, when it comes to the aspirin in this individual, it will be a chewable aspirin that can be given right even in the ambulance, sometimes even at the house of the patient. When the emergency crew will reach the house of this guy, definitely, aspirin can be given on the way to the hospital as well. Alphabet N would stand for nitroglycerin. We can give sublingual, and subsequently, if required, we will be giving nitroglycerin drip to this patient. This is the name of the drugs which are going to be useful for management of patients of unstable angina. And out of all the drugs that I've discussed with you, if they ask you to select one, obviously all of them are going to reduce mortality. That is why they are being used. But I want to highlight that if they ask you to select one and say which of the following is the drug of choice for unstable angina, you see, drug of choice is a very myopic view for anything, because we are using multiple drugs here. But if they ask you to select one, the one that will show maximum reduction in mortality is the one which at the moment will cause the perforators in the main coronary artery to dilate. So more blood you send in to the ischemic myocardium, more is the chances of salvage. And therefore, unstable angina, if they ask you single best drug that reduces mortality, it is nitroglycerin drip. I want to highlight this fact that when I was teaching you chronic stable angina, I said nitrates have not had any mortality benefit. I hope you recall that. But now in unstable angina, this is definitely going to be having a significant mortality reduction. I repeat the fact once again. Nitrates are for symptomatic relief in chronic stable angina, no mortality benefit. But the drug of choice for unstable angina is going to be answered as what I have just explained to you. However, now I'm going to create a bad scenario in the following sense, that my patient's SpO2, in spite of this treatment, is not improving. When he came, SpO2 was, let me say, 85% in room air. In spite of everything that we have done, it is 75%, in spite of the fact that he's on oxygen. The blood pressure of the patient is not picking up because the ischemic myocardium of the left side of the heart is not able to perform properly, and the crepitations in the chest earlier maybe were not present or were maybe scattered at the lung bases. Now the crepitations are more extensively present in both the lung fields. So if a person is not showing improvement, how do I know person is not showing improvement? I'll look at the parameters like SpO2, blood pressure value, crepitations. Like when he came, as compared to the admission value, if all these parameters have reduced, good, my person is responding to my treatment. But at the moment, let me say I have created a bad scenario for you, person is not responding to treatment. In those circumstances, what will you do? Your answer would be given as, you would be going in for a delayed percutaneous coronary intervention. Earlier, I was teaching you PCI with a drug-eluting stent for patients of single vessel disease or double vessel disease. The PCI word has come in the discussion once again, but you can see a prefix here. The prefix is delayed PCI. So the message is delayed PCI is also done in patients of unstable angina. But when would you do it? When the person has not responded to the conventional medication. So I'm just putting a word here, medically refractory. And how do you know it is medically refractory? Is not based on that the person is saying I'm having chest pain, right? I'm not looking at only the chest pain component. I'm looking at the hemodynamic parameters of this patient. I'm checking out the pulse of this guy, and I'm noticing that because BP is falling, therefore the pulse of the person is becoming feeble. So if he's not going to respond to my treatment, yes, I will take up the person in the cath lab and we'll be doing a procedure of balloon angioplasty, and that would be treatment of unstable angina. But this is not the first line treatment. This is a backup treatment only if the person does not respond to the treatment that you have offered him initially. Now I will be comparing this particular patient of unstable angina with the next one. who would be having rather a very surprising finding of ST elevation per se. I wanted to remember that in all anginas there would be ST depression. Chronic stable angina had ST depression on treadmill test. Unstable angina, I also taught you that 50% cases they would be ST normal, in 25% cases they would be ST depression. But now I want to tell you that when it comes to Prince metal angina, why do you call it variant angina is what I just said. It is called as variant angina because this is the only angina with a ST elevation. Well, we have a look at some baseline information also. There's a amino acid, you are familiar, arginine, which causes production of nitric oxide in the coronary arteries. Nitric oxide is a coronary vasodilator. Like if you're late for an exam, you are having, let me say, a professional exams or centups per se, and you walking fast towards the examination hall. So your and my coronary arteries will dilate because we are taking stress at that particular movement. But in people with Prince metal angina, this normal dilation of coronary arteries may not occur. Rather, they might be a spasm. Now, why that is happening is because there's an enzyme called as nitric oxide synthase. It is also 3 types 1, 2, 3. You know that from physiology. So I'm talking about nitric oxide synthase type 3. This per se is present in the coronary endothelium, and it is supposed to produce nitric oxide, which will be a coronary vasodilator. But this coronary endothelium and the enzyme inside it is malfunctioning. So the synthesis of nitric oxide in my patient of Prince metal angina will be lesser, and his coronary arteries will not be able to dilate, or in fact, due to complete deficiency or significant deficiency of nitric oxide, they might even constrict as well. I wanted to remember that when it comes to normal coronary endothelium, we are talking about specifically the coronary endothelium at the moment. Under normal circumstances in coronary endothelium, there can be release of acetylcholine, and this acetylcholine, it acts via nitric oxide only. I want you to remember that in a normal person, acetylcholine acts via nitric oxide and it contributes to coronary vasodilation. However, in people with Prince metal angina, if you inject acetylcholine into the coronary artery, it will not be able to do this job. Why? Because the enzyme responsible for synthesis of nitric oxide, NOS3, is not working. And why the enzyme is not working? Because the coronary endothelium is malfunctioning secondary to atherosclerosis. I want you to remember that in a normal person, acetylcholine injection will cause a dilation, but in Prince metal angina, acetylcholine injection causes a vasoconstriction. I repeat the fact once again. In a normal person, from physiology perspective, you would have studied acetylcholine, which helps in generation of nitric oxide, causes a coronary vasodilation, but in Prince metal angina, the spasm. Why the difference? The difference is what I highlighted. The coronary endothelium is not working properly thanks to the atherosclerotic process. So I just want to mention a provocative test though. Nowadays this provocative test is not done, but still because it is given in books, I want to highlight that if intracoronary acetylcholine is given in a Prince metal angina patient, it will be contributing to coronary spasm, and then we can relieve this spasm also by injection of nitroglycerin. This is a provocative test. This is not done anymore, in a sense that if you inject this and there's a spasm so severe that person develops MI, well, the responsibility will be yours. So this is only for academic reasons that we are studying that there's a provocative test available for Prince metal angina where injection of acetylcholine, because nitric oxide synthesis compromise, will not be able to cause a dilation but causes a constriction. Because of, I would say, the adverse effects of this test and the risk associated, it is not safe and advisable to do this test. In fact, in textbooks, it might even be written that we can do a coronary angiography to detect the spasm. I definitely agree to that. But the point is, if you are going to be doing angiography in this patient in the morning hours, maybe then you may be able to visualize the spasm, because you see vasoconstriction is more in human body in the morning hours. Because vasoconstriction is more in morning hours, so coronary artery constriction will also be relatively more. So if you go do angiography early morning hours, let me say 7 o'clock, 8 o'clock, when most cardiology units will start functioning, that is when you will be able to demonstrate the spasm. But in case you do coronary angiography in these patients post lunch, the spasm may not be present. So we do not rely as of now for diagnosis of Prince metal angina with help of only a coronary angiography. Clinically, with the details that I'll teach you, we can easily identify Prince metal angina. So these aspects, though are given in the textbook, are only of academic interest, and in reality nobody's uses, or I would say angiography is not the primary modality to identify this condition. Now I'll give you a clinical case presentation for the same that will make you relatively more comfortable. I'm describing a 60-year-old female who has come to me with complaints of recurrent attacks of chest pain. And when I asked her, ma'am, can you just describe the character of the chest pain? She's putting her whole hand on her chest to describe the oppressive nature of the pain. Now, when I listened to this, I was first taken aback. I was surprised. Ma'am, you daily were having diffuse chest pain? She says, yeah, I daily morning wake up with chest pain, and then as the day progresses, chest pain goes away. It's a very surprising that the question is himself giving you regarding diurnal variation of chest pain. I want to highlight in MI, it will be a single episode, guys. MI is going to be so bad, or unstable angina episode is going to be so painful that person will immediately seek your medical advice. But in this case, the severity of chest pain may be little on the lower side because after all, there is no necrosis occurring in the heart person. There's only a spasm. This is recurrent axial chest pain in a female, and also notice the fact that in all other coronary events, I have always incorporated a male patient, but prinzmetal angina, you will always notice gender wise, it's gonna be mainly a female patient. Also, I want to tell you, though this is just a general fact, that all the coronary events are more common on the left hand side. Mostly the artery that is involved is left anterior descending artery, but in prinzmetal angina, it's an exception to the rule. It is the right coronary artery which is usually involved. So two exceptions I've highlighted. One, I've highlighted gender wise it will be female. Second exception is recurrent attacks of chest pain described in the person, and then right sided events, or I would say the reason why this is happening, though any artery can exhibit a spasm, but incidence wise this is just an incidence based data that right coronary artery involvement has been found more in patients of prinzmetal angina as compared to left sided. So one, in the exam he may deliberately give you diurnal variation or diurnal nature of chest pain. In fact, there can be seasonal variation also present, because you see in winter months attacks of prinzmetal angina will be more because vasospasm will be more in the winter months. So if he is himself giving you scenario of either a diurnal variation or is mentioning regarding a seasonal variation, with the incidence being more in the winter months as compared to summer months, you would be able to actually catch this statement from given by the examiner, and you would start thinking in terms of that, oh, it is unlikely to be MI, it could be maybe possibility of prinzmetal angina. Then a piece of information can be given in the question. This lady is telling you that when she was younger, let me say when she was 30 years of age, she says, I've been to various doctors because whenever I put my hands in cold water, I find that there's a change in the color of the tips of the fingers. You very well know about Raynaud's phenomenon. The color change would be ranging from initially when she puts her hands in cold water, the fingertips will become white. Then there would be deoxygenated hemoglobin accumulating, so fingertip will become blue, and then subsequently there might be a reflex vasodilation causing fingertip to become red. So white, blue, red will be the sequence or Raynaud's phenomenon, and well, this would be present in the past medical history of this patient. So one, I want you to understand that Raynaud's phenomenon is a vasospastic disease, and prinzmetal angina is also a vasospastic disease, and both can coexist in a single patient. I repeat the fact once again. Raynaud's phenomenon is a vasospastic disorder. Prinzmetal angina is a vasospastic disorder. Both can coexist in a single patient. Obviously, this was when she was relatively younger, and now she is having episodes of chest pain which are causing more trouble. So I said, okay, ma'am, let's do your ECG. And when I saw ECG, it was showing ST elevation. I mean, the first impression of mine is admit this lady right away. She's suffering from ST elevation MI, but when I checked her cardiac biomarkers, when I checked her troponin I, troponin T, whatever is available, the values of troponin I were surprisingly normal. And I thought, okay, maybe she's presented early morning. She was the first case of mine in my OPD at 9 a.m. I thought maybe she woke up with chest pain at 7, and usually troponin I rises by 3 to 4 hours. So I decided to do a repeat trop I after 6 hours. Maybe after 9 hours. Serial troponin I values are turning out to be normal. You see, if it is myocardial infarction, if there's a necrosis, even if the person of MI comes early, if the admission value is normal, subsequent value will always rise. But in this case, even if you do a serial trop I values, they will definitely be normal. And that is why I'm at least assured of the fact that, thank God, she's not having a myocardial infarction per se. So I'm gonna be starting her on nitroglycerin drip. The moment I start the drip, the pain is gonna magically go away, and the patient will be literally requesting me for a discharge. But I'll tell her, ma'am, I would suggest that you stay with us for another day or so. Not that I want to do any angiography or any invasive procedure. It is just that we want to monitor you for maybe possibility of any arrhythmias that can occur secondary to the spasm. Once I have stabilized her, I will now shift her to oral medication as early as possible, isosorbide mononitrate. And along with this, I will also be starting her on amlodipine calcium channel blocker. Please remember, Why am I adding CCBs? Not because I just want to neutralize the spasm. See, the nitrates are anyway to be given to these patients because nitric oxide production is deficient. But if you give isosorbate mononitrate or nitrates for long duration, they can be tolerance. And because of the risk of tolerance, if isosorbate mononitrate is present in the blood for 24 or 24 hours per day, after a few days, tachyphylaxis will occur, the medicine will stop working. I need to ensure that there must be some drug free period, that is, let me say in 24 hours, 8 hours of drug holiday. 16 hours the drug is present in the body, 8 hours of drug holiday per day. And for those 8 hours, I can actually give amlodipine bedtime to these patients so that when they wake up in the morning, especially 5 a.m., 6 a.m., they do not suffer from any kind of chest pain. So lots of time you will also read, or you might actually send me a message saying, sir, pharmacologist has told us that the drug of choice for Prince metal angina is amlodipine. Please appreciate, the pharmacologist there is trying to say that you can prevent these episodes. Mark my words there. For acute episode, we don't give CCPs. If you give acute episode CCP, it might worsen the case because CCP has a side effect. No, amlodipine causes tachycardia. Acute episode treatment is nitroglycerin drip. That is to stabilize the patient right away. But once you stabilize, then you need to prevent the episodes from occurring. And therefore, for prevention of recurrent episodes, mark my words there, for prevention of recurrent episodes in Prince metal angina, that is where we shall be using amlodipine for these patients. And yeah, once I have done this activity, once he's stable, then I'll call her later on or for a follow-up also, because lots of these patients can be having chronic stable angina, that is multiple blockages in the artery. So don't be under impression, the discussion is going Prince metal angina, unstable angina, chronic stable angina. Please appreciate both can coexist. There's a possibility that a patient could be having 70-80% blockage in one artery. There could be only 40% blockage in the second artery, and that 40% blockage while a lesion might be throwing atheromembolic fragments into the distal circulation. So the same patient who was earlier having chest pain on exercise due to 80% blockage in one could now be having chest pain at rest because atheromembolic event is occurring in the other artery, that is unstable angina. So chronic stable angina can be present with any variety of angina. It could be coexistent with unstable angina. It could be coexistent with Prince metal angina also. I have tried to give you a discussion in black versus white, but they can be coexistence. Shades of gray also can be present. So work up later for these patients for chronic stable angina as well. That is, if required, coronary angiography would be required, or work up these. I mean, lots of time in MCQs because they don't love to or don't like to say this word CSA because that becomes very easy for you. So he might actually just put up this statement, work up patients of Prince metal angina for hibernating myocardium. Yeah, that's a correct statement. I mean, you will have to work them up because of coexistent nature of this disease per se. There's a possibility that earlier this person was having chest pain only on exercise, this lady, but now this lady is having recurrent episodes daily morning. And therefore she has come to you for advice. She thought it is gastritis. She's herself taken pantoprazole, or a family doctor advised PPIs, but since the chest pain was persisting, that is where your role comes in. And as I highlighted, there is no need for doing a provocative test in the form of intracoronary injection of acetylcholine and then relief with nitrates. Lots of time diagnosis can be made with the combination of the aspects that I have said. The next topic that I'll cover here is myocardial infarction, and I will begin by first describing the ECG findings that would be encountered in the case. First of all, I want you to be clear that if they ask you what is the earliest ECG finding in myocardial infarction, please do not answer ST elevation. It is rather increase in the height of the T waves. Now, this increase in the height of the T waves would be called as hyperacute T waves and not as tall tented T waves. Where do you read about tall tented T waves? Well, that would be hyperkalemia. But in myocardial infarction, the main point I want you to remember is the earliest ECG finding is hyperacute T wave, and I'll now demonstrate before you how it actually looks like. You see, you are familiar from our earlier discussion of ECG and arrhythmias that the vertical height of the T wave should be less than 5 millimeter when it comes to evaluation of the limb lead. So LL would mean limb lead criteria, and the vertical height of the T wave should be less than 10 millimeter when it comes to evaluation in the chest leads. Now, obviously, if the T wave height increases, then the values that I've said, either it could be a tall tinted T wave or it could be a hyperacute T wave as well. So when I sketch before you a hyperacute T wave, you will notice the fact that the breadth of the T wave has become relatively lesser, whereas the height component has increased, but it is very much below the height of the R wave. When it comes to tall tented T waves in myocardial infarction, there's a possibility that the T wave height might become even more than the height of the R wave. And I would also like to notice that the upper part of the T wave here is not very pointed, but it is rather a little rounded. So first and foremost, if they ask you, What is the first ECG finding in myocardial infarction? Your answer will be what I've just reiterated or highlighted before you. Your answer is hyperacute T wave, and do not answer tau tensor T wave, where the tip of the T wave will be pointed and the height will usually be more than the height of the R wave. This ECG finding will occur within few seconds of blockage of any one particular coronary artery. On some MCQs, instead of writing the word what is the earliest ECG finding, he might just say what ECG finding can be seen with myocardial ischemia, because first there is ischemia, then there is injury. So now we will talk about what can happen subsequently in the patient. Please be clear, not all cases have ST elevation. So though I'm writing ST elevation at the moment, I want to highlight that in 50% cases it could be STMI, in 50% cases it could be a non-ST elevation MI, and the treatment of both of them is different. Now let me demonstrate before you how a ST elevation in myocardial infarction will look like. So you will notice that the ST will definitely go up, but the topmost part of it would be relatively rounded, that is convex. When you will listen to the discussion of acute pericarditis, I will mention that there is a ST elevation once again, but it will be concave upwards. You can notice a distinct convexity at this particular junction. So this point must always be remembered, and lots of time in multiple choice questions, he might even put this classical name, Pardee sign. In some MCQs, an alternative term might be written, that is tombstone pattern. So either of the two, the bad news is that this person will definitely be requiring a angioplasty. That is, we will deploy a balloon in the coronary artery to destroy the thrombus that has caused a substantial obstruction. And he can also ask you what is significant ST elevation, because for male and for female patient, it would be slightly different in a sense that males, the size of the heart, or I would say the myocardial thickness, might be slightly different from a female. So there are two different criteria. For male, I want you to remember it should be more than 2 millimeter. For female, it should be more than 1.5 millimeter. And which leads will you check for will also be taught to you as we move down progressively. But at this moment, the objective of discussion is to sensitize you to the fact that if he begins the question by saying which ECG finding is seen in myocardial injury versus which ECG finding is seen in myocardial ischemia, then the answers are different. As you can see, first there will be myocardial ischemia, which will gradually become irreversible, and then subsequently injury will occur. That is when biomarkers will also begin to rise. And now let us look at what's going to happen subsequently, which is going to be cell death. In fact, you very well know from pathology, and he's trying to link up pathology with the clinical domain. First there is ischemia, then there is injury, and then there is cell death. And the ECG finding that will always be present because of cell death will be deep Q waves. I hope you recall that Q wave is very small in size. It usually fits into one small square in the ECG. If the Q wave in the ECG goes beyond or goes out of one small square, either vertically or horizontally, it will be called as a capital Q wave. And this deep Q wave indicates cell death. Well, what is the importance of it? The importance is that this ECG finding will persist for whole life of the patient, because even if you will do thrombolysis, you can reverse definitely the damage present in the heart partially, but you cannot reverse death obviously. So this deep Q wave will persist for whole life of the patient, and therefore in another year the question asked was which ECG finding is suggestive of previous myocardial infarction / old myocardial infarction. Like for example, patient had MI in 2020. When he came to me in 2021, I will definitely be able to notice deep Q waves, which will always persist in spite of whatever best treatment was given. It could be a primary PCI, it could be thrombolysis, whatever best we could do for the patient to salvage the myocardium was definitely done. But in spite of that, obviously you cannot reverse the death component, so this is going to be occurring, or this is going to be persisting for a longer duration. And the same information can be asked with respect to time frame also. Like I told you, what is going to occur within seconds, what is going to occur with respect to minutes. That's going to be a ST elevation, not all cases. So you will also notice another finding coming up here. That would be T wave inversion. I want you to understand the fact that T wave inversion can also be a finding of myocardial ischemia. In fact, you see here I'm trying to distinctly highlight the findings, but it could be like this. Initially there could be hyperacute T waves. Lots of time patients may not present very fast. You see lots of time in India, because of lack of transportation facilities, lack of awareness, patient might reach the hospital late. So in those circumstances you may not get hyperacute T waves. So this is okay from theoretical domain, what is the earliest ECG finding, but practically speaking, lot of patients when they reach the hospital might be having a T wave inversion. T wave inversion, I repeat once again, is a finding that is suggestive of myocardial ischemia. At the same time, once he says the word current of injury, in fact I should jot it down so that you can remember it subsequently. If he specifies the word, which of the following is the current of injury? This question actually came right from Genom. It is quoted from Ganong. What is the current of injury in MI? It is not T wave inversion, it is ST elevation. If he talks about what is the ECG finding of myocardial ischemia per se, then there can be two. It can be hyperacute T wave, or it could even be, I'm just writing a slash here to sensitize you to the fact that if a person will reach the hospital very fast, or if MI is occurring in the hospital, then okay, you might be able to identify a hyperacute T wave, but lots of time there might be a T wave inversion with a ST depression, that is a non-ST elevation MI also. So you need to keep your mind open for that. If he specifies the word injury, then the first answer is ST elevation. If he says ischemia, the answer can either be hyperacute T wave, not given in options, it is T wave inversion. And as I said, 50% cases could be having non-ST elevation MI, that is ST would either be normal or can be depressed and could be associated with T wave inversion. For the fourth finding, which I'm going to jot down before you, I'll first give you a small explanation. Now just listen to this part and then we'll come back to this slide once again. If you scroll through the ECG and if you look through lead number V1, then the height of V1, the R wave is relatively smaller as compared to the depth of the S wave. So I've written alphabet small r to highlight that the height of the R is lesser than the depth of the S. But when you will look at, mark my words there, I'm talking about normal at the moment, as you scroll through to lead number V3, then you will notice that the vertical height of the R and the depth of the S might become almost equal. But as you move towards lead number V6, you will always notice that the height of the R will now be more than that of the depth of the S wave. So I want you to understand that in a normal person, the height of the R wave tends to increase as you move from lead number V1 to lead number V6. Now, my point is in myocardial infarction, there is negativity in the heart. Negativity, why? Because necrosis is occurring. See, heart will be generating electricity. What I'm saying here in simple English is, just to explain, I would say the vector component, that because of the negativity in the heart due to death, therefore, the height of the R wave may not increase the way it should. I repeat the fact once again. R wave is a positive wave. This positive wave is generated due to the routine cardiac electrical activity. If the cardiac electrical activity overall generated is lesser because there is death in the heart, there is necrosis in the heart. So due to lesser current generation, the height of the R wave may not increase the way it should. And that is why in textbook it is written this statement that I say next, that is non-progression of the R waves. This is in fact itself a question. One of the important differential diagnosis of non-progression of the R wave is the topic that we're studying. That is going to be myocardial infarction. I repeat once again, why? Due to negativity in the heart. R wave is a positive wave, so the vector size or the positivity of the R wave will be relatively lesser, and the depth of the negative waves will be more. That is why the Q wave, which was the small q, was becoming relatively deeper q. So this is the sequence of events that will occur with time, that is ischemia, injury, and death. And I repeat the fact once again that when it comes to T wave inversion, I mean, I have tried to segregate into within seconds, within minutes, and very hours, but that's not a clear distinction. I mean, you can't draw a line and say that, okay, before this and after this, there's obviously a lot of overlapping present, which is why I highlighted the statement from the textbook that for injury per se, if asked, you will answer as ST elevation. If he says ischemia, it would be either of the two, hyperacute T wave and T wave inversion, and both are given, then both have to be marked. And these are the standard ECG findings that would be encountered. Now, where would you check for them? For that, you need to understand how the leads are placed around the heart. Let us say this diagrammatic representation represents the left and the right ventricular cavity and the muscle mass. I'm now showing here before you one of the important blood vessels which is going to be supplying the left ventricle, that is left anterior descending artery. I'm now going to give off a branch of the left anterior descending artery. This is the septal branch. I'm going to show one more branch which will curl around the left ventricle and run posteriorly. The reason I've drawn it dotted is because it is going posteriorly. That is the left circumflex artery. So three arteries have been highlighted here. Left circumflex supplying the lateral surface of the heart. LAD, the one that supplies the major surface of the anterior part right up to the apex. And then is the septal branch as well. Now, why are we studying this? Is because there are various electrodes that you're putting. Imagine the electrodes are like CCTV cameras which are scanning the heart. So electrode number V1 and V2. V1 can read a bit of right ventricle. I repeat the fact once again. V1 can study both the septum. You can see this particular area where I will just put dots here. This is the septum area. The septum area is scanned by the CCTV camera / electrode V1, V2, and some part of right ventricular cavity can also be scanned by V1 also. But as we move towards the anterior surface, so I'll just use a different color marker to highlight this. The part of a heart that is directly touching the sternum, mainly the component of the left ventricle, because you see left and right ventricle both would be obviously forming the anterior surface. Right ventricle mainly forms the base inferior surface, but it also contributes to the anterior wall. Now what I'm saying is major chunk, the word is major chunk of the left ventricle, which is facing the sternum, is supplied by the left anterior descending artery and is well read by electrode number V3 and V4. Now we will move more laterally. This lateral part of the heart, the one which I can say is from the axilla side, the one that you can scan from the axilla side, would be best read by electrode number V1, V6. So I just highlighted that V1, V2, then V3, V4, V5, V6. They are like electrodes which are scanning through the various surface of the heart. And the advantage of knowing this information is that suppose if there is a thrombus which will develop in the left anterior descending artery, then a major chunk of the left ventricle is compromised and the electrodes V3, V4, in fact all from V1 to V4 all will read it, but yes, V3, V4 are very strategically placed to pick up the ischemia. On the other hand, if you're having a thrombus developing, let me say in the left circumflex artery, I am just doing a symbolic representation with yellow here to say if there's a thrombus developing at the movement due to plaque fissure in the left circumflex artery, then V5, V6 are strategically located very close to this area to pick up the necrosis findings, which I've just highlighted. Could range from deep Q waves to ST elevation or could even be ST depression present. On the other hand, if there's a thrombus developing in the septal branch, then the electrodes which have been strategically placed to scan this area are electrode number V1, V2. So the message here is, let me say if person is having septal myocardial infarction, then V1, V2 will read. If it is anterior wall MI, then it is going to be V1 to V4. See, septum is also anterior, V3, V4 anyway going to scan the anterior surface, but V1, V2 is also going to be evaluating the blockage in the LAD. But if it is lateral wall MI, then in those circumstances the left circumflex artery is the one that is involved and electrodes V5, V6 will be able to scan it. So when Ihd designed the leads, he had this complex anatomy in mind, and from this discussion you can also see that right ventricle is the neglected one. In fact, that is one of the lacunae that were initially found with respect to ECG, that right ventricle is not very well represented. So this can also be a question for you. The question can say which chest lead can study the right ventricle. Now earlier I was saying that V1 can scan the right ventricle but only a part of it. I repeat the fact once again, lead number V1 can also be scanning right ventricle per se, but only a part of it. So if he says which chest lead is best suited to evaluate, the word is chest lead best suited to evaluate the right ventricle, answer is V4R. And what is V4R? V4R will be just like you put V4 on the left hand side. I'll speak about the electrode positions also. Like you're putting V4 on the left hand side, when you place V4 on the right side, we call it V4R. So after V4R, if V4R is not given in the options, then the answer is V1. Otherwise it is V4R best suited to study the right ventricle. As you can see, anatomically it can scan a bigger chunk of the muscle. Then he can ask you which augmented lead is best suited to study the right ventricle. The answer is not AVR. AVR scans mainly the right atria. It is AVF. And apart from this, lead number 2 and lead number 3 can also scan through the right ventricle. So especially when it comes to inferior wall myocardial infarction, a bigger chunk of right ventricle is compromised. In inferior wall myocardial infarction, the ECG findings are best evaluated in lead number 2, lead number 3 and lead number AVF. Mark my words there, I did not say AVR, I said AVF because AVR is mainly going to scan the right atria per se. Let us now look at the leads that were designed by Ihd to evaluate the various surfaces of the heart. I'll be describing very baseline data before you. So if you are aware of this, I think you can just sit back and relax and listen to what I'm saying. But if not, then you can just quickly brush up your baseline information. Lead number V1 is usually put in the fourth intercostal space. And I've seen a lot of doctors very casually answering second intercostal space, but that would not be the correct one. It is on the right hand side parasternal line, and this would be the fourth intercostal space. Lead number V2 will be a mirror image of lead number V1 only, but this would be put on the left hand side and everything else would remain the same. When it comes to lead number V4, it's going to be the fifth intercostal space on the left hand side, but now the line that we are going to use is mid clavicular. And well, for lead number V3, you will lots of times seeing the technician doing this activity, so you can do it by yourself also. In fact, every time you go to a ward, if you can just approach the technician to teach you how to put the electrodes of the ECG, you will yourself feel more comfortable, more confident. Lead number V3 is put by approximation between V2 and V4. Now, when it comes to lead number V5 and V6, it would still be the fifth intercostal space, but the line is gonna change. So it's still gonna be left, but the line will change from mid-clavicular to anterior axillary line. Then we move a little more, then would be mid-axillary line. So standard leads are V1 to V6. But sometimes to trouble you in the exam, there's a distinct possibility that the examiner might deliberately write words like V7, V8, V9. It's still gonna be fifth intercostal space, it's still gonna be left and left side, but the line will dramatically change. When it comes to lead number V7, it will be posterior axillary line. When it comes to lead number V8, it would be scapular line. And for V9, in fact, I can just put up as a question to you guys. I mean, usually I find people faltering with V9, so that's why I put it up as a question per se. Where do you place V number, lead number V9? And that's gonna be little more posterior to the location of lead number V8. Well, your answer would be paravertebral line. So in fact, I was just trying to test your English at this particular juncture. And well, why are we doing this hard work? Especially for V7, V8, V9, we are talking about studying the posterior surface of the heart. So in MCQs of posterior wall MI, you will specially notice that V7, V8, V9 may be written. We will talk about the localization of myocardial infarction in a few seconds from now, but first I need to tell you the arrangement of the leads. And the standard chest leads that we are going to be deploying are going to be labeled from V1 to V6, though V7, V8, V9 may be written. Now we will talk about the limb leads as well as the augmented leads, and the term augmented lead is used because the voltage output is relatively better. You see, to draw this triangle per se, you just have to put on some markings, and the markings would be for the left arm, for the right arm, and the left leg. And lead number 1 will be connection between the left arm and the right arm. Lead number 2 will be connection between the right arm and the left leg. And lead number 3 will be connection between the left arm and the left leg. I have again seen people messing up between lead number 2 and 3 by inverting the information. How to remember this? You can go anti-clockwise, and usually, I mean, they can link up physiology with medicine. So lead number 2, I highlight once again, is the connection between the right arm and the left leg. At this juncture, I had a query from a student. He said, sir, if somebody is having amputation, like it's a soldier and maybe a grenade went off very close to him, so he has an amputation, like both arm amputation or maybe even a tetra amputation. You can, instead of a grenade explosion, you can take a scenario of a guy who had a train accident and his arms got amputated. So can you do ECG in a person who's having a tetra amputation? The answer is yes. You can put the electrodes on the stumps. So yes, ECG is possible in people with amputation. In fact, there's no contraindication for ECG. Only one practical issue I can say is that for a Parkinsonism patient, because he's having that resting tremor, there's a possibility that if you're doing ECG in a person of Parkinsonism, then due to the resting tremor, there might be artifact that would be coming that might look like ventricular fibrillation, but there's a solution to that also. You see, usually the tremor of Parkinsonism tends to disappear when the person is sleeping, so you can do the ECG when the person is sleeping. The message here is that as such there is no contraindication, and leads connections have to be remembered, especially the ones that I've highlighted, and lead number 2 and 3 are the only ones where possibility of error is there. Now I will study, or I will describe regarding augmented leads. In fact, this was again a physiology based question, that why is this augmented lead called so? So the reason why that is so is because the voltage recording is better. In fact, the voltage in augmented lead is 1.5 times higher as compared to the voltage which is present in the limb lead. So especially for chamber enlargement, augmented lead data can be used. Lead number AVL will study the left surface of the heart. Lead number AVR will study the right surface of the heart, especially the area related to the right atria. And one of the highlights of lead number AVR is that the first wave of the ECG, the P wave, and the last wave of the ECG, the T wave, is negative. You will always notice that P and T are upright waves, but when it comes to AVR, it is going to be ulta, it's going to be reverse. So lots of time I might be actually saying, like in pericarditis literature, you will read or you will hear me saying ST elevation in all except AVR. Why? Because AVR is physiologically placed in such a fashion that it will read all the data inverse of whatever data that is coming in the routine leads. So AVR is going to study the right atria per se and not the right ventricle. Right ventricle is relatively inferiorly located. So if he says, how do you scan the right ventricle? Your answer is AVF. You can imagine AVF is like a electrode put or a CCTV camera put on the top of your foot, and it is scanning your diaphragm. and touching your diaphragm would be some part or significant part of the right ventricle which has been infarcted. So to study the right ventricle, we use lead number 2, lead number 3, and lead number AVF, and do not answer lead number AVR as I've already sensitized you to. Well, Ithovan was a very revolutionary and a very far-thinking individual who changed the way we look at medical science. In fact, at this juncture, I would like to name some important doctors who have changed the way we are looking at medical science, or I would say they made the entire medical science very electrical. What I mean by electrical here is that EEG was invented by Hansberger, whereas ECG was invented by Einthoven. And when it comes to a stethoscope, it was not Littmann. You see, we all aspire to purchase an expensive Littmann stethoscope, but well, who invented the stethoscope? It was Lennox. Yes, we read about Lennox and Rosses, right, in pathology. So Lennox is the one that we credit with the invention of the initial stethoscope, and now we obviously have more sophisticated variants of it available. But these are the name of some of the scientists which I would just like you to be aware of, not only from exam perspective, because they are the ones who were, I would say, many years ahead of the doctors at that point of time, and they changed the way we look at medical science, and they electrified everything, especially Einthoven and Hansberger per se. So in the honor of Einthoven, this is the Einthoven triangle, and they also have what they teach in physiology as Einthoven law. Though I think everybody knows about Einthoven law, I can request you to remember a number 213. Well, the voltage in lead number 2 will be a sum of voltage in lead number 1 and lead number 3. Remember this statement of mine, 213, 213 for Einthoven law. The sum of voltage of 1 and 3 is equal to the voltage in lead number 2. That is Einthoven law per se. And the advantage of studying this baseline information is that you feel relatively more comfortable, especially when you're scanning the coronary arteries. Well, where do coronary arteries originate from? So they originate from the root of the aorta. Now, as you're aware of the fact that the first branch of the aorta is the coronary artery, so here I'm representing right the base of the aorta. I've represented the root of the aorta, and this that I've highlighted is the ostia from where the coronary arteries will be originating. The site of origin of the coronary artery is the aortic sinus, and the first blood vessel that I'm highlighting at the moment before you is so precious that if this blood vessel gets blocked, then most of the time patient may not reach the hospital. He might die in the ambulance or even at home. This is left main coronary artery, and the thrombus in this can be really lethal. Now I'm going to show a branch of the left main coronary artery that is going to curl around the left atria and is going to go relatively posteriorly. So this blood vessel that I'm now going to mark before you will supply the posterior surface of the heart as well as the lateral surface of the heart, and this is the left circumflex. Now I'm going to draw another branch of the left circumflex artery that runs on the lateral surface. This is called as obtuse marginal. Well, what they can do is that in the exam they can link up the electrodes that I'm talking about with respect to the blood vessels. So obtuse marginal branch, if it gets involved, it is the lateral wall of the heart that would be affected, and the blood vessel that is continuing at the moment will be the one that you will be involved in 50% of cases of MI in your clinical practice. I mean, in any tertiary care hospital when you will work, you are anyway in the casualty see myocardial infarction patients. As I've highlighted right in the starting of the lecture, that coronary artery disease is a big time killer in India, but 30% of mortality in India occurs because of coronary artery disease. So the blood vessel that can get involved in the person is the one that I'm talking about, left anterior descending artery. This is responsible for anterior wall MI, and 50% cases in clinical practice are of anterior wall MI. Now I'm going to show you two branches of the left anterior descending artery which are called as D1 and D2, that is diagonal 1 and diagonal 2 branch. And if you're aware of this anatomy from your anatomical classes, great, but if not, then I would definitely like you to continue listening, because another branch that I'm going to now highlight on the contralateral side is the septal branch. This septal branch will be supplying the interventricular septum, and if this gets involved, if there's a thrombus in this one, then septal myocardial infarction can occur. I will now be highlighting another aortic sinus and a coronary ostia from where the right coronary artery of the patient is starting, and this is going to be supplying the right ventricle, and an important chunk of the right ventricle will be forming the inferior surface of the heart. I am now showing a branch which is running posteriorly. You can see that there are two blood vessels on the posterior surface of the heart, so I'm really not worried in a sense that even if one will get blocked, the other one will still be like an elder brother taking care of the area supplied by the one that has been blocked. This blood vessel that I've currently marked before you is called as posterior descending artery, and is easy to remember from the exam perspective, because if he says which blood vessel is involved in posterior wall myocardial infarction, remember earlier I was teaching you posterior wall myocardial infarction, the leads that you will be using, special ones are going to be V7, V8 and V9. Now I'm saying the fact that when it comes to posterior descending artery, if this gets involved, then it can be posterior wall MI. And in fact, of posterior wall MI, I said there are two blood vessels, posterior descending artery as well as the left circumflex artery, and any of the two can definitely be affected. The objective of doing this exercise is to sensitize you to the fact that if a thrombus occurs in this blood vessel, then the type of MI that will develop in the person will be answered by you as extensive anterior wall myocardial infarction. As I highlighted, there would be a cardiogenic shock developing in the person. That patient may not reach the hospital, he might die in the ambulance or on the way to the hospital. In contrast, if the thrombus occurs in the left circumflex artery, then it would be a lateral wall MI that will be well studied by lead number V5 and V6. On the other hand, if the thrombus occurs in left anterior descending artery, this will contribute to the commonest type of MI, anterior wall MI. I've repeated this information earlier also so that you are able to retain this. The involvement of the septal branch, well, it would cause a septal myocardial infarction. And most importantly, they love to ask this, right coronary artery thrombus will contribute to, because I said right ventricle forms an important component of, in fact, the surface of the heart that is touching the diaphragm, that is inferior surface. So right coronary artery thrombosis causes inferior wall myocardial infarction. And for posterior wall MI, there are two answers, but if they ask you to select one best answer, then for posterior wall MI, I have not seen people making mistakes, because posterior wall MI begins with P and the blood vessel here is also beginning with P. That is a posterior descending artery. So the objective of studying all this information is that you are able to mentally visualize the leads, which are going to be like CCTV cameras scanning the heart, the various surfaces. And on the basis of this information, I'm very sure that the subsequent discussion that Mark mentioned before you, especially for the various parts of the heart getting involved, will become relatively much more easier to comprehend and understand. Our objective would be in this discussion to talk about especially leads that are to be looked by you in the exam when they give you a ECG based question to scan through, which electrodes are to be primarily evaluated to pick up the specific changes that I highlighted in the starting of myocardial infarction subtopic, and then you will be able to tell which surface of the heart is involved. I want to highlight, you should have the capacity not only to diagnose a MI, you should also have the capacity to tell which surface of the heart is involved by looking at the ECG. Assisting you in this will also be cardiac biomarkers, because if he is going to give you information about cardiac biomarkers, your job will become relatively much more easier, because you would be having gross elevations. And one of the important biomarkers to be remembered is troponin I and troponin T. And well, if let me say, a friend of yours, he's a non-medico, and he sends you a report right now on WhatsApp, and he says, buddy, my dad was having chest pain since morning, it was tremendously increasing, so some family physician advised us for troponin I. Can you just have a look at the report and tell that, is it something important? Should I go and rush to the hospital? Then troponin I should become elevated by how much that you will say myocardial infarction is present. The normal values will depend on the kit. Like usually you will see some of the kits mentioning normal value of troponin I per se to be less than 0.04 nanogram per deciliter. So my point is, if normal value is given, more than how much would be myocardial infarction that is to be considered as significant. So I want you to remember that at least doubling should be present. So if the trop I values are, let me say, 0.08 nanogram per deciliter, that implies yes, it is significant. I'll tell him, buddy, rush to the hospital. You can also have a tripling, you can have a 5 times elevation, you can even have a 10 times elevation of normal. That's definitely a cause of concern. And in fact, from the exam perspective, very important questions coming up, two of them. One, if he says up to 5 times elevation can be seen with, your answer will be type 4A myocardial infarction. And this I described when I was describing PCIV stenting for a person who's having single vessel disease. So you can go back in the lecture and have a look at treatment of chronic stable angina. When I described single vessel disease, that is where type 4A MI came into the picture. In contrast, if he puts up a question, and I'll give an explanation for this also subsequently, if he says about type 5 myocardial infarction, this occurs during coronary artery bypass grafting, up to 10 times elevation can definitely be present. So majority of MCQs. So if you read a multiple choice question that begins by the examiner himself saying that a person having chest pain at rest is having elevated biomarkers, your job is done. It means that he's talking about myocardial infarction. The technical definition of elevated biomarkers will be written as more than 99th centile of the upper reference limits. To simplify things before you, I said doubling or I said tripling can be present, because depending upon how severe the damage is, the values of tropi can dramatically increase. But the technical meaning from the exam or the textbook perspective, elevated biomarker, practically I told you 2 times, 3 times, right? But in the exam, in the textbook, they write like this. So even the statement you should be very comfortable with. And one of the important tests that we will always do will be CPK-MB also. Now, what is the importance of CPKMB per se in the exam is, whenever he will talk about a reinfarction, listen to my next words with lot of care. If you get a multiple choice question that is talking about reinfarction after 72 hours, then you can definitely answer a CPKMB. Otherwise, if reinfarction after 72 hours is not given, because it is not a guarantee no that reinfarction will occur only after 74 hours or 72 hours, or let me say 76 hours. Reinfarction can occur even after 1 hour also. Like at the moment, it is the left anterior descending artery that was involved, and then subsequently in the person, it was right coronary artery getting involved. So there is no guarantee that reinfarction will occur only after 3 days or 4 days. If a reinfarction is occurring early on, then what test will you do? It can be troponin I as an answer. In fact, I want you to remember that the value of troponin I will dramatically rise if there's a reinfarction, because already one artery was involved, now a second one is getting involved. So if you get more than a 20% hike, I repeat the fact once again, you have already done troponin I in the person once when he came to you initially. If there's a 20% hike over the baseline value, I'm not saying, what I mean by the word baseline value is not that baseline is normal. Baseline is already elevated because he had a blockage of left anterior descending artery. Now over and above this, like let me say the value at admission was 0.08. Now it has jumped to 0.1. Now that's definitely a 20% hike over the baseline admission value. So I want to highlight that when I say the word baseline admission value, it does not mean that it is normal. It was already elevated. Now the second episode has pushed up the values even dramatically, much higher. The final message that I want you to understand is, the best test for diagnosis of MI is not ECG. There is a possibility that a person might come early, then ECG may not be able to identify the changes or significant findings may not be present. But cardiac biomarkers will always get elevated if there's a necrosis occurring in the patient. And I will also tell you the limitations of ECG as we progress. But at the moment, I want you to remember this statement of mine. I mean, any question with chest pain and talks about elevated biomarkers, it is implied. I mean, if he said this word by himself, it implies myocardial infarction is present, and you don't need to worry about then subsequently whether, you need to think that there's a diagnosis of MI or not. You need to proceed now. The question can be then, is he talking about complications of MI? Is he talking about the management perspective? Is he talking about what is the first line management that is to be done? So this is a very important statement that will straight away simplify things before you. And well, as far as cardiac biomarkers are concerned, there's a table which is given even in pathology, and I'm going to discuss it once again before you. So let's do a quick revision of these biomarkers. They take how much time to rise, when will they peak, and when the values will fall. You see, CPK-MB was the answer when I was a student at your age. They used to ask what is the best test for identification of myocardial infarction. We used to answer CPK-MB gross elevations. The problem is that CPK-MB will rise, but the rise might take as much as 4 to 6 hours. Whereas when it comes to troponins, the rise will occur relatively earlier, that is about 3 hours. And at this junction, I also want to say, like in Delhi, there are so many cardiology hospitals. Like at the moment where I'm recording, 3 kilometers away from here would be Max Hospital. Maybe 7 kilometers here from here will be Fortis, and maybe AIMS next door. So point is, patient will have so much of choice whether I should go to, if somebody is having chest pain, should I go to AIMS? Should I go to let me say AIMS Hospital, or should I go to Max Hospital or Fortis Hospital? So my point here is that if a person will come early, then if he comes lesser than or earlier than 3 hours, so when you read the word serial troponin I, it means the fact that one, you can check the value of troponin I at admission, and you can repeat it the same after, let me say, 3 hours or maybe as late as 6 hours. So if it's a genuine case of MI, obviously the later values will be elevated, but I'm not saying that you will wait for the values to be elevated and then starting treatment. The first test to be done for evaluation of any person is ECG. ECG has its own limitations that I'm going to tell you, but at the moment the message is that if a person came with chest pain at rest, if ECG is showing evidence, we are not going to wait. Like somebody came within 1 hour, I'm not going to wait for the tropi values to become grossly elevated and then okay, it is MI. If ECG is showing finding, fine. That is why it is written in the textbook, ECG and or biomarkers. I mean, any of the two, if it is positive, you can start the treatment of the patient. Well, there will be no questions on the peak values per se because the peak values are pretty constant. All of them would be peaking at around about 24 hours, but fall definitely will vary. For CPKMB, the fall occurs by the third day, which explains the fact that why I was saying that if somebody suffers from a MI again on the fifth day, or let me say the fourth day, then CPKMB will rise. CPKMB values came down, then it will rise once again. But when it comes to troponin T or troponin I, they remain elevated for relatively longer duration. For troponin T, it is 10 to 14 days. For troponin I, it is 7 to 10 days. If they ask you to select between trop T and trop I, then select trop I because quantification of this can easily be done. The highly sensitive tests that we have, we can quantify what is the magnitude of rise. Is it 0.04 or lesser? That is normal. If it is 0.05, 0.06, yes, the ischemia part is very severe and injury will definitely occur subsequently. And if there's an injury, then values will always become double and even higher than that, depending upon how much blood vessel and which critical blood vessel has been involved. If they ask you what is the first marker to rise in myocardial infarction, then in pathology they might talk about myoglobin. I agree to that, but myoglobin is not very specific because myoglobin is present in skeletal muscle also. So I want you to remember an important marker, that is HFABP, that is heart fatty acid binding protein. Please remember heart fatty acid binding protein. This is an important test, or this is an important marker that can identify myocardial infarction as early as within 1 hour of onset of MI. With advancement of technology, kits are being developed for all these markers and will become available in India as well. So yeah, I mean, if you read the medical data, if you read especially American journals, you will find hospitals doing heart fatty acid binding protein in America or in Europe. And gradually, all the information will percolate down to India as well. So we shall definitely be using this marker for early identification. But till then, there is nothing that we are short on because anyway ECG can identify the ischemic findings and the injury findings even if person comes early. So biomarkers are only for confirmation of diagnosis. Then I was also talking about the fact that ECG can have limitations. So let me highlight one of the limitations before you. Let us assume this to be the left circumflex artery, which can be scanned by electrode number V5, V6. Now suppose there's a thrombus exactly at this area where the artery is taking a curvature and electrode number V5, V6 are scanning it, then I can say like every CCTV camera will have a blind spot. See, if I say, let me say my hand is a CCTV camera, then it can scan all the distant areas, but it cannot scan the area immediately below it. You see, like our eye has a blind spot, even CCTV camera will have a blind spot. So V5, V6, the blind spot is the curvature of the artery. I mean, V5, V6 can scan the entire coronary artery. The LCX circumference can be scanned, but this area which I've highlighted where the artery is taking a curvature, this part may not be actually evaluated by V5, V6, and therefore in spite of the thrombus present there and there would be substantial necrosis also occurring in the muscle, the findings may be missed by the electrodes. The problem is not of, I would say, that there is no elevation occurring. I mean, the current of injury is occurring, but you are not being able to pick up no because of the limitation of your technology. So one, I want you to remember this statement that left circumflex artery ischemia is poorly localized by ECG. This is one of the limitations. I have always been praising ECG for diagnosis of myocardial infarction. In fact, I began the discussion by telling you the ECG findings within seconds, within minutes, within hours. But now I'm criticizing it by saying that it is a fault with the technology that we are using, that okay, the electrodes are having a blind spot. So left circumflex artery ischemia is poorly localized by ECG. That is one of the limitations. And another one that I wanted to remember is even right ventricular ischemia is relatively poorly localized, in a sense that when it comes to the right ventricle, we will have to put a special chest lead, that is V4R, and V4R is not put routinely. So there are two statements that are made. I mean, these are two limitations of ECG. Left circumflex artery ischemia and right ventricular ischemia is poorly localized by ECG. If they ask a single best response, which artery ischemia, mark my words there, if they say which artery ischemia may not be identified with respect to evaluation by ECG, then the first answer in the question should be given at left circumflex artery. Overall, I have highlighted like this. CPKMB will become elevated by 4 to 6 hours. The values will be elevated by 24 hours and will come down by 72 hours. So, if a person will have, this is, let me say, the third day, the values are coming down. If a person will have a myocardial infarction on the fourth day or on the fifth day or so on, then the values of CPK-MB will again begin to rise. So you can see that this curve is basically trying to explain to you that in creatinine phosphokinase myocardial band, MB is not muscle, it is myocardial band, BAND. So the full form of anything you should always be knowing. CPK MB is creatinine phosphokinase myocardial band. You can see the values will come back to normal, then will spike again, maybe on the fourth and the fifth day. So if MI is occurring after the third day, okay, CPK MB. But otherwise, for all the MCQs, the minimum message I want you to remember is, if the question says what is the best test for myocardial infarction, if he says what is the investigational choice for myocardial infarction, in fact I highlighted the word elevated cardiac biomarkers. This is just that the examiner is trying to trouble you by using all these terms like most specific test for diagnosis of myocardial infarction. The answer is serial troponin I values. Serial would imply that even if the person will come early, you still will be finding necrosis anyway occurring. So evidence of necrosis will be documented after few hours. But treatment is not gonna wait. Treatment has to be started right away. And well, you can identify MI by either of the two. Either it is ECG or biomarkers. Either the two will be useful for you initiating treatment in the patient. So let us now summarize the infarct localization in myocardial infarction. I will here be mentioning regarding which surface of the heart is involved. Then I will mention the blood vessel which has been affected by the thrombus. And we will also look at what are the leads which are to be checked for to pick up particular surface of the heart getting involved. As I've already sensitized you, if it is going to be the lateral surface of the heart getting involved, then the blood vessel involved will be left circumflex artery and the obtuse marginal branch of it. The leads that you want to scan here are lead number V5 and V6 along with 1 and AVL. It's primarily V5, V6 from the exam perspective that you need to remember, and by default anyway, lead number 1 and AVL will be scanning the left surface of the heart. In case he talks about septal myocardial infarction, then it is the septal branch which was starting from the left main coronary artery that will get involved, and the electrodes which are best positioned to scan this will be electrode number V1 and V2 along with 1 and AVL by default. But if he talks about anterior wall MI, 50% of cases are of anterior wall MI, then it is left anterior descending artery that would be affected, and electrode number V1 to V4 will be evaluated to check for anterior wall MI along with 1 and AVL. Now what I find a problem for most of the students is simply carelessness, because when he will just introduce the word extensive anterior wall myocardial infarction, I'm writing AW, that implies anterior wall myocardial infarction, then the blood vessel that is getting involved here is the left main coronary artery, and because the thrombus will be fairly extensive and a chunk or a large amount of cardiac muscle will be involved in this case, so findings will be seen from all the electrodes, that is V1 to V6, 1 and AVL. And well, how to remember this information? I can say that if you are listening to me carefully, if you add the top three, if you add lateral plus septal plus anterior wall, it becomes extensive anterior wall MI. So do take care of the fact that in the question, has he mentioned the word anterior wall or extensive anterior wall MI? Then he can also ask you regarding posterior wall involvement, where the blood vessel involved is posterior descending artery. The second one would be left circumflex, but first answer is posterior descending artery. And the electrodes that you would check for here would be V7, V8, V9. Now the problem is that V7, V8, V9 are not put routinely by the technician. So how would your technician come to know that he has to put V7, V8, V9 without you having or you giving a proper instruction? So first of all, you as a doctor should identify that if any question or any, I would say, patient in clinical practice, V1 to V4 is showing a ST depression. Listen to this carefully. If V1 to V4 is showing a ST depression, you should ask your technician to put V7, V8 and V9. And if he mentions that ST elevation is present in V7, V8, V9, you see two information should be given together in the question, because we are talking about reciprocal changes in this particular case, because damage is in the back. So when you put electrodes on the back, you will have a ST elevation. But if it is going to be V1 to V4 ST depression, both information should be given in the question for you to answer posterior wall MI. So just by looking at V7, V8, V9, do not comment on anything. Both information should be given. Now, why that is important is because once it happened in the exam that he mentioned that a person is having V1 to V4 showing a ST depression. And he said which surface of the heart is involved. There was no information given for V7, V8, V9 in the question. If V1 to V4 alone is given in a question, then guys, this patient is suffering from non-ST elevation myocardial infarction of the anterior wall, which means that the answer to my question, I said which blood vessel is blocked here, would be answered as left anterior descending artery. See, the point is, if it is non-ST elevation MI, V1 to V4 will anyway be having ST depression. So you have to put V7, V8, V9 by default. If it shows a ST elevation, cool, that's definitely a posterior wall MI. If nothing is given in the question or there were no changes documented, it's a non-ST elevation MI of the anterior wall. And when I describe this information, usually, we tend to get frustrated by the time we reach towards the end of the table and the examiner knows the fatigue factor will start coming in. So lots of time the questions will actually begin by saying inferior wall MI, which is always given in every textbook right at the bottom, and the examiner will pick up from there in inferior wall MI, which leads will be used. I have already sensitized you to this, so I don't think so it will be too much of a drain on your energy or precious resources. It would be lead number 2, lead number 3 and AVF. I again repeat, it's not AVR, it is AVF. So this entire table I would suggest you to note down by yourself, but the minimum that I expect you to remember without any glitch is one, a question of extensive anterior wall MI where V1 to V6 are the ones that will be showing the finding, and inferior wall MI where it's going to be lead number 2, 3 and AVF. And ideally, I mean, if you scan through the entire table, it will be rather a confidence building exercise for you. And now let me say that if they have given you a printout in the exam, they will be giving you a printout of a 12 lead ECG and you will be able to, or you will have to tell which surface of the heart is involved. So this is how the arrangement is. It is lead number 1, 2 and 3, and lead number 2 is given right at the bottom also. In fact, this continuous lead number 2 that is given at the bottom is best used to evaluate the heart rate. And always whenever you are evaluating the heart rate, check out the RR interval and don't count RR interval only once. At least make it a habit to check it twice, because otherwise you might miss out a irregular RR interval of atrial fibrillation, multifocal atrial tachycardia. Then will be the augmented leads information that would be given. That is lead number AVL, AVR and AVF. And as I told you, AVR, the P wave in the T wave will always be upside down. Then will be the chest leads, that is V1 to V6 respectively, with V5 and V6 scanning the lateral surface and V1, V2 scanning the septal area and some part of the right ventricle. Now this is what I'm saying. If in the exam you are noticing a ST elevation occurring of 2 mm with respect to a male or more than 1.5 mm for a female in the following leads, V1 to V4, this implies the fact that the person is having an anterior wall MI. And apart from this, I also told you that in anterior wall MI, the same finding of Pardee sign or tombstone pattern, whatever you want to call it, can also be encountered in lead number 1 in AVL. However, suppose I'm just doing a color change here. You are getting a multiple choice question in the exam in which the changes are found in lead number 2. There's a ST elevation which is present in lead number 2, lead number 3 and AVF, and you will find lots of such questions whether you are using my app or anybody else's app, or I mean, you will find lot of questions on what I've just highlighted, that is inferior wall myocardial infarction. So please do not miss it out, because this part may not be scanned in a rush. We tend to focus on the chest leads, and he's having you or giving you a finding with respect to lead number 2, 3 and AVF. So the information that is shown in color black here is for inferior wall MI, and the information that is shown in color red, in this case the color coding red for ECG, is for anterior wall myocardial infarction. And as I've already told you, if it is going to be changes right from V1 to V6, it's going to be extensive anterior wall MI. So the objective of ours here was to understand infarct localization. Had I talked about this infarct localization without explaining to you regarding the arrangement of the leads or the diagram of the blood vessels, it would not have made too much of sense. So you guys have studied this in your basic sciences, but now I hope that you are more comfortable understanding this particular table. So my message is that don't simply move on to this table per se. First, try to focus on the baseline informations that have been provided. Just a quick revision here of some of the aspects I have already explained. If he says what is first to rise in MI, there is no controversy, guys, that in pathology it is different, in medicine it is different. In fact, pathologist is also saying the same thing as I am, that myoglobin is what is given in the textbook like Robbins, because you see, a pathology book will always talk about a postmortem scenario. But as clinicians, as somebody who's gonna be handling patients in real time, I'm not worried or I'm not interested in myoglobin, because that could be false positive elevation also due to DC shock. Myoglobin, you see, when you give a DC shock, no, skeletal muscle will also be damaged. So myoglobin can be elevated due to maybe a DC shock delivered to the patient. So how do you know whether it is elevated due to DC shock? Is it due to skeletal muscle trauma or soft tissue injury that the patient sustained before he died? Or was it actually primarily because of damage to the heart? So therefore the correct answer is heart fatty acid binding protein. And if like one is not in the options, then okay, you can answer as myoglobin. Now also another piece of information here, if he says what is last to rise in MI. Now this is only for academic reasons, because for me as a clinician, I am definitely not interested in what is last to rise, because my objective is always early diagnosis. But this is only for academic reasons. I want you to remember last to rise in MI is LDH. Just remember from the L alphabet, lactate dehydrogenase. Though LDH again, it is not going to be very accurate in a sense that LDH is present inside RBCs also. Lots of time they might even talk about LDH1 and LDH2 ratio also. So I can just mention the fact that if it is LDH1 divided by LDH2 ratio, then the 1 should be in the numerator, 2 should be in the denominator. That is the flipping effect that they basically mentioned in the MCQs. So whenever there is a flipping of values mentioned of LDH, then again it signifies that it is myocardial infarction. Though this is primitive information in a sense that nowadays nobody uses LDH1 and LDH2 ratios for scanning MI. We have much more advanced tests like troponin I, which can identify the diagnosis. The final summary is, guys, if somebody is coming to you with diffuse chest pain, see, somebody is if having GERD, he will point with his finger on his retrosternal area like this and he will say, sir, I'm having chest pain. So if somebody is pointing with his finger like this, that's okay, that could be GERD. But somebody is having a diffuse chest pain, he's putting his whole hand or his fist on the chest to say, sir, very oppressive pain, then we are talking about Levine sign. Now Levine sign implies diffuse chest pain persisting in anybody for more than 20 minutes is to be thought of as myocardial infarction till proved otherwise. There is obviously a possibility that in some MCQs he might actually say patient presented after 3 hours, 4 hours. Why? Because you see, he has to tell you about the rise of troponin I, because troponin I will not rise substantially immediately. It will take some time to rise. My message is, if anybody is having diffuse chest pain for more than 20 minutes, you should suspect myocardial infarction to be present in a patient till proved otherwise. And the first test to be done in the person is anyway ECG. There can be two possibilities. Either ST elevation will be there or it will not be there, which implies that there could also be ST depression given in the question along with T-wave inversion. Along with this, you will also use biomarkers. I have highlighted the concept of serial troponin I for early identification. Tropi should be ideally exhibiting a doubling, and between the two is written and an or to basically highlight that any of the two can be positive. Like if a person comes to the hospital early, ECG will still be showing evidence. Now comes a very interesting bit of information which can be useful from the exam perspective, that he's giving you a scenario of a person on the operation table suffering from MI. Let me say this person is undergoing cardiac surgery itself. The chest is open and patient is undergoing cardiac surgery and he suffers from myocardial infarction. Then if the chest is open, it's not that we'll close the chest and put electrodes and identify. In those circumstances, ECG may not be able to pick it up. And tropi does not rise immediately. It rises after, let me say, 3 hours, 4 hours. And I want to know right now. So therefore, a third test that I want you to remember at the moment, which can help in identification of myocardial infarction, especially in intraoperative scenario, is transesophageal echocardiography. And transesophageal echo will show evidence of decreased contractility, because let me say right coronary artery is thrombosed, there is a big infarct present in right coronary artery, then the muscle will obviously undergo necrosis, right ventricular function will be compromised. So he will use the word stunned myocardium for describing the decreased contractility of the heart. So there are 3 investigations which can be used. Any of these can be used. Any one of these is positive. If they ask you to select one, then the first answer is always troponin I. I highlighted that right in the beginning. Elevated cardiac biomarkers more than 99 centile of the upper reference limit of the baseline values is always a conclusive fact that the person has suffered from MI. But yeah, he can ask you about ECG, he can ask you about tropi, and he can ask you about transesophageal echocardiography as well. And from the ECG perspective, I can also add one more aspect here, that if a person has had, this is optional for you, if you want to note it down, this you can skip skip also because bundle branch block topic I have discussed separately. So additional information from ECG that can be added. It's not optional. It's optional for you at the moment. That is new onset left bundle branch block, because the problem in bundle branch block of the left side is that left ventricle is not going to contract on time. And what is the problem with the left ventricle will not contract on time? The blood will try to come in the left side from the lungs. But if the left will fail, if the left will not contract on time, then this blood that has to move into the left ventricle will not be, I would say the compliance of the heart is compromised. So filling of the left ventricle is lesser. So blood will tend to accumulate in the lungs itself. Repeat the fact once again. Right ventricle contracted, left ventricle contracted. Left ventricle is not contracting on time. It was supposed to, once it will contract, it has to receive blood. If it will not contract on time, it will not relax on time also. If it will not be able to receive the blood, all the blood will accumulate in the lungs and it will cause pulmonary edema. So left bundle branch block can be lethal and can be seen with myocardial infarction. The ECG findings of left bundle branch block are discussed separately in a lecture, so I don't want to confuse you at the moment. So this is optional that I've highlighted. What is present in the notes is the three informations which are important for understanding. Any of the three, ECG, tropi, transesophageal echocardiography, if positive, means a myocardial infarction with Levine sign. This is the main crux of this discussion. I mean, I would suggest you to again note it down so that you can remember this information. And most importantly, I said that it can be either the two types of MI that could be given. So 50% chances is what we find by incidence, and any of these investigations would help you in confirmation. And I will also now sensitize you towards the end of this particular part 1 of acute coronary syndrome regarding various types of MI which are given in the 20th edition of Harrison. So let's quickly have a look at the various subtypes that he has talked about. That is type 1, 2, 3, 4 and 5, and 4 is subdivided into 4A and 4B. For type 1 MI, guys, I want you to remember that it is atherosclerosis which is the villain. In fact, that's the word that I started this discussion with. And if a person due to this atherosclerotic lesion is then having a vulnerable plaque, and the vulnerable plaque then fissured and the collagen was exposed, platelets jump onto the opportunity, and there's a thrombus developing in the coronary artery, it is type 1 MI. In fact, if a person is hypertensive, then in a hypertensive patient, you might even have a coronary artery dissection, and the coronary artery dissection is again related to damage to the blood vessel per se due to the progression of the retrograde aortic dissection. You see, aortic dissection can travel antegradely towards the carotid artery, it can travel antegradely to the brachiocephalic trunk, but retrogradely, the aortic dissection can travel into the coronary artery also, and that would be type 1 MI occurring in a patient. And you will not do thrombolysis in coronary artery dissection because there is no advantage of doing a thrombolysis in a tear in the artery. I mean, the person will unfortunately die. Now, suppose he talks about a young guy going to a rave party and he did cocaine overdosage, so that will cause spasm of the coronary artery so bad that the person will develop type 2 myocardial infarction. So if you read about non-atherosclerosis based reasons for MI, then it could be type 2 MI. Like suppose this lady, she's having severe anemia, her hemoglobin is 5 and she's pregnant for, let me say, third time in last 5 years. She's pregnant for third time in last 5 years. Every time anyway, pregnancy takes a toll on the body of a woman. And in India, especially rural India, if a woman is having severe anemia, then availability of oxygen to the heart will be relatively lesser. So maybe the third or the fourth pregnancy can be lethal for her. She can die during her delivery time, not only because of heart failure, but because of myocardial infarction also. Next scenario can be that of a patient who has slept in an apartment with a gas geyser on. Especially in urban India, you will now find an increased incidence in small apartments of gas geysers being used and people developing carbon monoxide poisoning. In carbon monoxide poisoning, carboxyhemoglobin is the major hemoglobin. Oxyhemoglobin is less. If the heart will not get sufficient oxygen, the person can die. So if it is non-atherosclerotic lesions contributing to MI, it is type 2. If it is atherosclerosis based lesions, then it is type 1 MI. Type 3 myocardial infarction is described for patients having sudden cardiac death, and there can be two reasons for that. One could be like the ambulance crew received the call. By the time they reached the home of the patient has expired, or maybe while they were transporting the patient to the hospital, the patient expired. The reasons for these can be varied. One could be a tachyarrhythmia that will be described in part 2, that is ventricular fibrillation, or it could even be ventricular tachycardia, or it could be a bradyarrhythmia as well. The bradyarrhythmia that that can cause sudden cardiac death and the heart rate to drop down to as little as 20 beats per minute is Mobitz to heart block. So I repeat the fact once again. Tachyarrhythmias that can occur in the first hour of MI can be ventricular fibrillation. VT usually occurs by 12 hours after onset of MI, and bradyarrhythmias, Mobitz to heart block. Any of these can cause sudden cardiac death. So patient came to the hospital, blood sample was already drawn for biomarkers, ECG was already done, and then he simply collapsed. I had allocated a bed for the person, and suddenly I found the daughter of this old man started crying, and I just got up from a chair, went to the bedside, and the patient was gone. I tried giving CPR, but I lost the patient. By the time I could even introduce a defibrillator, before I could actually do a evaluation of why this patient suddenly collapsed, the person had expired. That is type 3 MI. For type 4 MI, it is two subtypes 4A and 4B. For 4A, I want you to remember this can occur during percutaneous coronary intervention and was discussed even in chronic stable angina topic. For type 4B MI, I want you to understand that we are putting a stent in the coronary artery. Now, stent is after all also a metal, no? So metal and platelets don't go together. So it is the stent which is ultimately contributing to thrombus formation. So you have relatives telling you that, sir, my father had a stent put in his coronary artery 20 years ago, and today he has developed a MI. The possible reason could be the stent which was present in the body for such a long duration that ultimately resulted in a thrombus formation and could contribute to mortality in the patient. That is latent stent thrombosis. And type 5 MI, I would call this guy a very unlucky chap. Why? Because he's on the operation table. He's undergoing a coronary artery bypass grafting. Now, while undergoing a coronary artery bypass grafting, can somebody develop MI? There can be two reasons for it. One reason can be that, let me say, during coronary artery bypass grafting, they do it on a beating heart nowadays. There was a possibility that there was a lot of bleeding in the operating area. And the surgeon who's doing the surgery today is a junior guy. He's a rookie, let me say. He's doing his first case unassisted, and the senior is on the leave. So there's a possibility that because there was sudden bleeding in the operating field, so he started putting clamps. And unfortunately, he put a clamp over the aortic sinus. If you put a clamp on the aortic sinus, then the coronary artery supply is totally gone. So I can put it that the surgeon himself was responsible for mortality, that if you clamp the main blood vessel that supplies the heart, the person will die. Or I can say that when you're putting bypass grafting, you're obviously using an operating microscope and you are putting sutures in blood vessels. Suture itself is a foreign material that can even also trigger a thrombus formation. So type 5 MI can usually be either due to, I would say, negligence on the part of the surgeon and clamping the left main coronary artery itself due to sudden bleeding in the operating field, or by performing bypass grafting in the patient. Well, type 5 MI will also have a very special finding which is now to be remembered. That is, the elevation of troponin I will be at least 10 times over and above what you see routinely. And with type 4A myocardial infarction, the elevation of troponin I can be as much as 5 times of normal. These are two MCQ statements that I definitely want you to remember. That is, elevation of troponin I more than 5 times of normal is not seen in type 5 MI. In type 5 MI, it is 10 times elevation. In type 4A, it is 5 times elevation. I've highlighted these 2 points at least twice. And this is a new table given in the 20th edition of Harrison that you definitely should be familiar with. And this is more on etiology. I mean, what actually triggered myocardial infarction. Whereas prior to this, the subtypes of MI that I was teaching you with respect to the surface of the heart that is getting involved. So both of these aspects should be known to you. That is infarct localization as well as types of myocardial infarction. And as far as the treatment aspect is concerned, that I'll be describing in the subsequent lecture. So these are the details which are important for this particular part. So keep learning, guys, keep hammering, and thank you for your patience and hearing me out, especially for this relatively longish lecture, but there's more coming up in the subsequent one. Thank you.